Good morning, everyone. My name is Mark Filizzi. I'm the principal investigator of the Opioid Workforce Expansion Program grant, and I want to welcome you all to the Recovery and Continuum of Care training, which is sponsored by the Opioid Workforce Expansion Program grant, and it'll be presented by Blueprints for Addiction Recovery Incorporated. Again, I'm Mark Filizzi. I'm the principal investigator of the grant, but the really important people who work for the grant are here with us today. Ms. Gwen Burkholder, who's our program coordinator, who is responsible for the day-to-day operations of the grant and basically tells me where to be and where to go. And Ms. Danielle Horning, who is our graduate assistant, who's responsible for setting up the Zoom call that you're on today. A couple of things I just want to mention before we get started today. I do want to welcome all of our presenters, and we're grateful for your ability to be here today. We're thrilled to represent from Blueprints for Addiction Recovery, Mr. Dave Augustine, who is the Outreach Coordinator and Certified Recovery Specialist for Blueprints. He coordinated the presentations for multiple team members today, including Ashley Cayley, Brooke Sauer, Dan Hamilton, Deb Smith, Lori King, Alexis Miner, and Clarice Tinson. And feel free to clap or wave your hands now through Zoom. I'm afraid I'd be cut off. We're also grateful here at the OWEP grant for Dave Augustine's participation on our advisory board. In addition, Melissa Callahan, Blueprint's Corporate Director of Nursing, will discuss medicated assisted treatment and harm reduction from 12 to 1:30 p.m. today. We've invited additional guests for that time frame, including nursing students and preceptors from the Millersville University Department of Nursing. I also want to welcome all of our participants, and here's another opportunity to use your technology and clap or wave through Zoom. We want to be sure to welcome all of you, including professionals from many organizations within our Pennsylvania communities and from out of state, as noted by the introductions on chat. And you can see, if you will, it looks like everybody is checking in on chat, just mentioning who you are, where you work, where you're from. The MSW OWEP students who are completing the program are from both Millersville and Shippensburg University. We're honored that people from the following universities, in addition to Millersville and Shippensburg, have also registered to join this training, and from California University of PA, from Temple University, Elizabeth
Hi. I think I
sign into your LGH account.
Sorry. Bowie State University.
How do I mute myself?
Technology. West Virginia University, University of Pittsburgh, Waynesburg University, and Chatham University. The School of Social Work and the Department of Nursing at Millersville University were awarded a $1.3 million HRSA grant to address the opioid epidemic through the Opioid Workforce Expansion Program. Essentially, the purpose of the grant is to better prepare MSW and DNP graduates to address the prevention, treatment, and recovery aspects of opioid use disorder and substance use disorders throughout the lifespan. Research shows that the interprofessional collaboration among many will make the biggest difference in our communities to address the opioid epidemic. We are collaborative, and we do not subscribe to the idea that territory is something that each individual discipline should maintain. Again, we are collaborative, and we realize that staying within silos has not been effective. I'm going to risk sounding a bit political now in this time of an election, however, and say that together we can go further and do more to address all aspects of the opioid crisis. So again, collaboration is the key. So just a few more things before I end and turn it over to Dave Augustine. As you've already been doing, please be sure to introduce yourself in the chat function. Use your first and last name and your organization to everyone, or privately to Danielle Horning. This is the way we can take attendance throughout the day, both now and for after lunch. Please keep your mic muted and your video turned off unless you're asking a question to a presenter or joining a discussion with the group. If your mic is on, make sure your cell phone or any other device is off as well too. Dave Augustine and his team will address whether or not they want to take questions throughout the presentations, or if they want to hold questions until the end of each presentation. Again, you can also type questions in on the chat function as well too, and the presenters will be able to read that as they speak. The lunch break will be scheduled from 11:30 a.m. to 12 noon. All right, barring that, I want to welcome Mr. Dave Augustine and his team. And I want to thank everybody for participating today and for attending. And again, I want to thank the leadership team of the OWEP grant for putting this wonderful presentation together. So everybody, please join me in welcoming Mr. Dave Augustine and have a great training. Thank you very much.
Okay, thank you. Can everybody hear me okay? If you're not, don't all speak at once or anything, because that could get a little confusing. But one other thing that Mark did not mention, I do have a second computer here for questions and answers. So there's a participant in here that says Blueprints Q&A. So we were going to have questions go that way. We have a number of presenters on our team today. So it will basically be by their discretion of how they want to handle questions. I'm going to do the introduction, talk about a few things here, who we are as a team, and also have a portion on certified recovery specialists and two programs that we do here at Blueprints for addiction recovery, which really works as the opening and full continuum of care, and that is our Second Chance Pennsylvania and PACMAT program. I may be moving that to the end for our closing part of the presentation. So we'll just see how the time works for that. But I do want to say thank you to everyone for participating. This is a big project for us to do. I originally got involved with the OF program due to my outreach. I do outreach with Blueprints, and I'm also a certified recovery specialist. And I got involved because the opioid epidemic affected me personally. It is something that I see with many people I'm very close to. And I myself personally am in recovery and have been since 2006. And part of what drew me to Millersville University was I first got in recovery while I was in college in York, Pennsylvania. And I didn't understand the resources that were out there. There may have been resources, I just was not aware of it. Now in 2020, you're starting to see these resources are much more readily available. And I just thought this was a way for me to help give back and do what we can to educate people to the best of our ability. So we are doing the continuum of care. It's recovery in the continuum of care. And I looked for a few different definitions of continuum of care. And the definition on the screen is a concept involving an integrated system of care.
Looks like 8 kids. I'll just give you a sticky note that says one.
That guides and tracks patient over time through a comprehensive array of health services spanning all levels of intensity of care. And this is the National Library of Medicine's definition. When talking about drug and alcohol recovery, there are many people involved that make the continuum of care work. And that's kind of how our presentation is going today, where we have a large team of people involved in all aspects. So we have Deb Smith, Melissa Callahan, who's joining us remotely. There's me, of course. Lori King is a clinical supervisor. Clarice Tinson is counselor assistant, who's also doing some classes with Millersville. Ashley Cayley is our director of admissions. She'll be joining us after I'm done. But by having this team of individuals, and also Alexis Milner, clinical supervisor, also has been taking some classes at Millersville. Dan Hamilton, our technology director, and Brooke Sauer will also be joining us to talk she's our billing manager. And this is a rough idea of the outline of how we're going to be presenting today. We're trying to keep everything in the best order of the continuum of care. As I mentioned before, I will be talking about, be doing the introductions as I'm doing right now, talk about outreach and community relations and certified recovery specialists and the role that they play. Ashley Cayley, our director of admissions, she's going to go over the admissions process, entry to care process, and it may seem like that's just a simple phone call just to get into treatment and get that help, but there are many barriers that can get in the way of that, and she'll be able to explain how we overcome those barriers. Brooke Sauer is our billing manager, and billing may not seem like much to do with the continuum of care, but She's going to talk about a lot about the different policies, especially with telehealth. Since COVID-19, we've had to pivot a lot in the treatment industry, and she'll talk about some of the stuff there. Dan Hamilton, our information technology director, is going to talk about the implementation of telehealth and also how telehealth and HIPAA play a role. Our clinical site director, Deb Smith, is going to go over the ASAM and part of the ASAM criteria. After that, we'll be joined remotely by Melissa Callahan, who's our chief nursing officer. She's going to discuss withdrawal and the detox process. We'll have a lunch break, and then she'll jump back again and talk about a MAT and harm reduction. Lori King is our, let's see, what is her position? I apologize. She is our clinical director, and she's going to be joining us to discuss the inpatient process and residential care. Alexis Milner, our clinical supervisor at the PHP level of care, is going to go over the partial hospitalization program, and that is for our PHP facility located in Mountjoy, Pennsylvania. Deb Smith will jump back on to discuss outpatient supervisory role. Clarice Tinson will discuss individual and group outpatient level of care. Finally, I will wrap things up talking about aftercare and long-term recovery. So who are we? Who is Blueprints for Addiction Recovery? You know, some people may have heard of us, and if you did, that's great. That means that we're doing our job. We're getting our name out there. This picture on the left is part of where we're located. So we're currently in our outpatient office in Lancaster, Pennsylvania, over in Greenfield Corporate Center. As mentioned, we also have a facility in Mountjoy, and that's our PHP facility. We do have our website if you ever want to check that out to get more of an idea of how everything is laid out there. So a little history about us. So we were founded in 2016 as a daytime and evening outpatient facility in Elizabethtown, Pennsylvania. Our founder, Chris Dreisbach, had started some recovery houses in Lancaster, Pennsylvania, and there wasn't a lot of recovery houses in the area, and that's a very key aspect to recovery. You know, there weren't many options, so Chris kind of took it in his own hands to start that. He was getting bugged by a few people in the recovery house to say, "Hey, when are you going to open a treatment facility? Let's do that. Let's do that." So finally, you know, one of the original members of Blueprints, Brooke Sauer, is going to be sharing as well. So she was one of those people that was bugging him to get things going. So we originally started in Elizabethtown, just kind of doing everything we can, and the belief was to give the same level of care regardless of funding capability, of county funding to medical assistance and all the way up to private insurance. You know, we understand that can be a big barrier, so having that accessibility goes a long way. We expanded to York, Pennsylvania, where we opened an outpatient facility in 2017. And then we now have residential units, which started in February of 2018, and that's called our Chapters program, and that's PHP level of care, which Alexis will be touching up on later this afternoon. The building we're in now is an outpatient level of care, and that's in Lancaster. And today, we currently have 3 residential PHP sites, so 3 residential sites. So it's a PHP counseling center in Mountjoy with 3 houses, 2 in Columbia, Pennsylvania, and 1 in Helen, Pennsylvania, and we provide transportation to get our patients to the PHP counseling level of care. So there I am again. I am a CRS as well as Certified Recovery Specialist. I will touch up on that as well to go over what that role is. But I do outreach here with Blueprints for Addiction Recovery. And again, like I had mentioned, outreach is what pretty much brought us together today. So there's many layers to the outreach aspect. And as mentioned, the PHP and outpatient level of care is what's handled here at Blueprints for Addiction Recovery. However, there's a lot of times where I'm dealing with individuals that need more than the outpatient level of care, need more than PHP. So by me having connections and working with other facilities throughout, usually throughout the state, some in Maryland, New Jersey, Ohio, so bordering states as well, just working with other facilities, because we know that more times than not, our facility might not be the facility that's going to be able to offer the best level of care to the individual. So I'm going to discuss the importance of working with these partners, whether that's treatment facilities, hospitals, medical practices, community resources, and recovery houses. And then we'll wrap it up with certified recovery specialists and different roles that is played there. That may be something we do later, or it might be done in this first 45 minutes. We'll just kind of see how things go. And I'll be fielding questions too at the end. I'm going to be monitoring some of those as well.
Okay. Can everyone hear me okay? Yeah. Okay. How are we doing? A little better now?
Yeah, it sounds better.
Okay, I apologize about that. It looks like the camera on our main main screen shut off. Okay, I have no idea exactly where we were left off at, so I'm just going to I have to pull the presentation up on a different screen right now. So basically, I was talking about the outreach process and the understanding of, okay, treatment facilities where we left off. Thank you, Amy. I just have to get the PowerPoint up over on this screen now. It's a Friday, right?
Mm-hmm.
I know, but I have to pull up so they could share it with them. So with treatment facilities, so I could just say for an example, so we work with, there's different facilities that accept different levels of care and also accept different types of insurance. And it's real important to know that because there are people seeking treatment every day, all walks of life, with all forms of funding, whether that's county funding, medical assistance, or private insurance. And then you have to understand that, like, even if somebody has private insurance, you'd think that they could probably just get access to pretty much any level of care or treatment, but that's not always the case. And sometimes it can be a bit of a hurdle to navigate all of that for people. So by staying connected with people on a pretty daily basis and just working together, referring out and referring back and forth, what that does for us then is having that relationship helps us get people into treatment much quicker, because we understand that that willingness window is very short for an individual that's trying to get into treatment. And we need to jump on that window as soon as possible. I know this from personal experience. I know there was a question asking me about getting into treatment. Okay, I think I can share my screen now. This is great. A little backup plan here. Everyone seeing that screen?
Yeah, I see it.
Perfect.
Yeah.
Okay. Sorry about that. I was trying to do everything on the fly there. So if I like repeated myself a few times, that wasn't intentional. Okay. All right. So let me just get back on track here. Okay, so I was saying that there were numerous ones throughout the state that we work with, and then understanding the level of care that they offer. And that's not just drug and alcohol treatment facilities. That's not just like another rehab, like another detox or inpatient, but a lot of times we're going to run into issues where an individual needs more than just drug and alcohol treatment. And that can be a dual diagnosis facility or primarily just mental health. And by me understanding the evaluation process that takes place within Blueprints or any other facility for that matter, like we see that happen a lot within the hospitals. We have partners that we work with there. We'll know if somebody, we don't want to be a disservice to someone. So knowing what can be offered to help the individual. For example, right, not far from us, right across the street is Community Services Group, which is a primary mental health provider. And last week, we did some outreach with them. Granted, it was virtual, just like this, but having that capability to have a partner like that, because there are many times where we'll see people that need that drug and alcohol treatment. But with that said, we also know that that's only part of the battle. We know that the mental health aspect may need approach too. So by us presenting to CSG and saying like, hey, this is what we do. They present to us, say, this is what we do. Find that collaborative effort. We look at that in many aspects because not everyone is the same. It's not a cookie cutter approach in any way. I had mentioned hospitals as well. So we do a lot with Penn Medicine, and we're very grateful to have partners with Penn Medicine and other facilities such as WellSpan and UPMC. But being local in Lancaster, we do see a lot with Penn Medicine and Lancaster General Health Group. I also do, I'm also on the board there with the Joining Forces. So just these kinds of boards and having those relationships, it just helps us with getting individuals into the appropriate levels of care. Many times we have individuals that are in our facility and we realize that we can't handle what's going on. We know it's a more medical emergency, and having connections with people within the hospital to be able to speed that up, to get people in and know that once they're discharged, we can get them back into our care and also know what needs to be monitored. So a lot of times we are working to send clinicals back and forth with each other to kind of just keep tabs on everyone and keep everything on the same page to the best of our ability. It's tough to do that at times when you have people going to other facilities, both medical. Is that working okay?
It should.
Okay, we'll rejoin that later. That's all right. All right, our other camera's working again. We'll probably just join that after I'm done. Yeah, so another very important thing is the community resources. And, I put a few examples on here, mainly just because without knowing these resources, a lot of times when people are seeking treatment, they're not really, an old cliche term is they're not really coming in on a winning streak. And that's not to talk down on anyone. It's just we understand that there's needs that they're going to have outside of us. And I'll talk about this a little bit more with as being a certified recovery specialist, but understanding these resources such as homeless shelters. We work with a shelter called the Rebel Cause, which is in Lancaster City. We get a lot of calls from them where people are looking for help. And they don't have much, and we understand that there's places that can help them get clothes, get fed with soup kitchens. And also a really important thing, our 12-step meetings and alternative recovery groups. When I say alternative recovery groups, those are, it's not AA or NA, but that's just, there's, for example, there's a group called Celebrate Recovery and other types of groups that go through churches. And then schools and universities, like we said, just trying to get our name out to you guys, understand, trying to teach some stuff to you guys that we have been taught. One of the things, so we have an individual that's doing a Narcan training on Monday with you. So that is just part of just trying to be able to give back, to help out. Stuff on the chat. I just want to double check this. Okay. So with recovery houses, that is an aftercare housing component. That is not affiliated with, those are run independently. A lot of times outpatient clients will stay at recovery houses. It's not a requirement, but it is usually recommended. It's pretty important to understand, like knowing, having a working relationship with these owners and understand, like, we want to make sure we're recommending good facilities, like good recovery houses. Because we've seen recovery houses before that have come and gone, they folded up, and they're just kind of people trying to get rich quick kind of thing, which I don't think that's the best way to try to get rich quick, but most people we see running recovery houses are doing it because they're passionate. They want to help. So there's multiple houses located throughout Lancaster County, York County, all throughout the state. We do a lot with the Lancaster recovery houses, and when we have in-person outpatient services, we transport and help people with that. We also know too, a lot of times patients will be on MAT, and certain recovery houses don't allow for that. So we have to know which ones do accept that. So some of them do and some do not. I'm gonna try to jump over on this other screen real quick, and then I'm gonna look at some of the questions too. So bear with me just 1 second. I'm gonna get off of this one. Okay, I did see, is there still feedback issues coming?
I can hear you fine.
Okay, I turned off both microphones. Okay, I'm gonna look at other questions that came through before I jump to the next area. Okay, so Anthony, you'd asked me more of a personal question about what made you seek treatment, or was there a certain scenario that occurred that influenced you to seek resources? So I can definitely, I'm very open to answering that question. I wanted treatment. I didn't know how to get it. I didn't know how to ask for it exactly. So there was a intervention that was held for me. And it was probably, at the time, I thought it was the worst day of my life. And today it was the best day of my life, because here I am. It wasn't, I wanted it, but I didn't know how to quite seek it. And today, I'm hopeful that we can help people that may have been, dang, there's no feedback coming. I do apologize about the audio issues. Of course, this is happening. But yeah, so to answer that question, I wanted the help. I didn't know how to seek it. So hopefully now today, that stigma of addiction is not so much a thing. Okay, so I'm going to, okay. So if anyone's unmuted, just based off of the chat, just go ahead and mute yourselves because that might be causing the background noises. We're going to stay on this video. We muted all of our other microphones over here. I'm just going to continue on with sharing my screen for the next part of my training, which is on the role of certified recovery specialist. Okay. So certified recovery specialist is also known as a CRS. We assist others in recovery from substance use disorders. Must have at least 18 months of sustained personal lived experience in addiction and recovery to become a CRS. So that is a unique type of requirement, is having that actual personal recovery free of drugs and alcohol. So currently right now the requirements, I believe that breaks down to 54 hours of training. It's not, usually it's 9 6-hour classes. Talks about recovery management, education and advocacy, professional ethics and responsibility, confidentiality, and relevant to field of addiction. Many treatment centers, and this must be renewed every 2 years as well. So there are a lot of treatment centers that are employing certified recovery specialists, mainly due to the fact that having that person with that lived experience goes a long way with helping others that are seeking treatment. So in a nutshell, it is a certified recovery specialist is the main point of contact and more of a treatment navigator that can help implement recovery service plans to help follow through at the continuum of care. And those relationships that were discussed earlier, such as with staffing agencies, clothing banks, soup kitchens, shelters, recovery houses, and 12-step groups, is very vital in this position. So I had mentioned that we have a program we work with the police in Lancaster County, different law enforcement officers, and that's called Second Chance Pennsylvania. It's an interdisciplinary team of addiction treatment professionals, which are the CRSs, and law enforcement and government officials that advocates citizens and determines to do our part in turning tables on addiction, relapse, and needless death. So basically, this is a police diversionary program. And what that is having CRSs on staff that work with the law enforcement. Many times we're going to see individuals that get pulled over that have possession charge, or they might have paraphernalia. Something that just seems like, does this person need to go through the legal system, or does this person need treatment? And a lot of times it's treatment is an option for them that may be what's needed. Me personally, if I had gotten pulled over and was offered that, that would have been, that kind of goes back to that question that was asked about getting that little nudge into treatment. A lot of times there's people that want that help, but they just don't know how to seek it. And having the police departments in Lancaster County working to try to help these individuals get into treatment, so the police officers understand if somebody has a problem and they want help, but then it's, where do they go from there to take over? That's where it can become very, it can be tough. So that's where the CRSs come into play. We show up and help. We can do an assessment on the scene. Let's see. So it's a 24/7 service because addiction and treatment, there's no timeline. Like it's always needed, whether it's at 2 in the morning or 2 in the afternoon. We're always going to see that individuals are seeking help, and we have consents that need to be signed so that we can help navigate the individual's treatment plan. And there are times where there's charges that are present, but the police officer can hold those charges in hopes that that individual is going to follow through on that treatment plan that's been laid out for them. So a lot of times you can see where an individual wants that help with treatment, but then they kind of start, like when they start to see like, hey, I might not get charged for this. Maybe we're okay. You know, that's why we have consents for them to sign. So it's like, well, no, we lay out this treatment plan. This is what we want in the best interest. So we use those resources that were discussed earlier with outreach, such as the detox facilities, hospitals, to help speed up that process of placing the individual into treatment. Sometimes it's very clear cut. It's very easy to get somebody in. All we can do sometimes is set them up for a drug and alcohol evaluation. They come in for that. It takes 2 hours for the evaluation to determine a level of care. Other times there may be somebody that overdosed recently, and we know they may need to go to the hospital. So we call up the drug and alcohol department over at LGH. We get them into the ER as soon as possible, or EMS will take them there, and then we help take over from there. There's other times where there can be an individual that gets pulled over at 1:30 in the morning for having an expired registration, and the officer finds a loaded rifle with 6 grams of meth in his vehicle. This person did not have a rifle to harm anyone, but instead was an avid hunter. But that's still a loaded weapon. So those could be some heavy charges. And these are not made up examples. This is real life experience. So I can use this experience. This is a very good example of somebody that was presented with, listen, here are your options. 6 grams of meth and a loaded rifle can usually get some heavy jail time and also lose his hunting license, never get to hunt again. Or maybe we can help you out, but you need to follow through with these steps because really the officer can hold these charges for up to 2 years. This individual I met with at 1:30 in the morning in a police station, and by 9 o'clock that morning, that's still the same morning, he was in our office doing an evaluation, which while he was doing the evaluation, because he was trying to tell me he wanted to just do outpatient level of care, which I knew in my mind that wasn't going to work for him, but you know, kind of throw him a bone. Let's just do the evaluation and see what the evaluator says, because really I don't have the same kind of training as somebody on the clinical team. So it's always good to work hand in hand with that to get that person through the level of care that's needed for them. So with this individual, he went in, did his evaluation, and then turns out that, hey, he needed more than that outpatient level of care, but he was willing to try it because he also knew that he had some charges that could really, really affect his life moving forward. And as of now, this individual has completed inpatient PHP and intensive IOP and general outpatient, and is following that continuum of care. He's a great example of someone we can talk about. And he's not the only person that's done this. We've seen this happen with numerous others. We've seen other people that have done really good and they're doing so good for 6 months. And then the next thing you know, they're not doing good. So that's why it's important to have a CRS that's going to be calling that person. They're doing some check-ins, because just going to some inpatient and some outpatient, it's great. It helps a lot. It's a great tool, but it's not a guarantee. So by having these consent forms like the one you see on the screen, there's many different types of ways to check these off. This is a pretty general way, but by having these, we have that ability to stay in contact with the people. And also, if they're at different facilities, there's a person I'm working with right now that's in a facility that's not in Lancaster, Pennsylvania, but I've been able to connect with her because she signed a consent, and this is legally I can do that. Her mother can call me and ask about her, and I can look and see there's not a consent signed for her. And I have the unfortunate task of saying I cannot confirm or deny that person's presence and treatment. So there's definitely some hurdles and bumps that can get in the way. And then I can also talk about examples of people that act like they really want that help, and they do, and they seem genuine, but at the same time, I have to understand, being that I'm a CRS and somebody that's been in those shoes in the past, that I used to say these things that I really wanted help, I really wanted to do this, but at the end of the day, I knew like there can be an alternative, and I'm going to figure it out. And that's just kind of the mentality of somebody that's suffering from OUD or SUD. And this gentleman, we were able to place him, and we had a bed held for him, but then he wanted another bed. He wanted to go somewhere else because he wanted to be closer to home. But I knew he couldn't get placed there. And since he signed consent forms allowing us to recommend the best level of care, he technically could not choose that. So we're being more that goes back to what was talked about with that treatment navigator role. Not to say that we know it all, but it's more of like, we understand what's going on with you, and we know that we're going to place you in the best level of care as possible. Anyway, that individual did not end up following through. And I had to call the arresting officer to let him know what was going on, because there was a consent signed for that officer, and there always has to be, because they're basically giving them an option. It's not a get out of jail free card. It's more of like, hey, here's an alternative. If you want to follow through with it, great. If not, we have the right to still charge you. So we do see that. And unfortunately, some people just aren't ready, and we understand that. You can't force somebody into treatment, but you can kind of help give them a little bit of a nudge. And that brings me to my last slide, which is Pennsylvania Coordinated Medical Assisted Treatment, or PACMET as it's known. This is a new program that we've done. We partner with Penn Medicine, Lancaster General Health, and the Addiction Medicine Department there. There's an MAT program. You may see a lot of signs throughout the county of opioid addiction, and it has the Penn Medicine sign on it, and that's for their addiction medicine department. So basically, the gist of that is the LGH care coordinators do contact blueprints, and we have a CRS that's dedicated to meeting with these individuals that are on MAT. And we gather information from the care coordinators and then meet with that individual face to face. We track everything that's going on and work to create a recovery plan for the individual that's on the MAT. It's a case-by-case basis of how they'll meet, if it's weekly, bi-weekly, monthly. And we kind of work with them to figure out what is that plan with the MAT, and is it something that they want to be on long-term? Are they trying to do it short-term? What kind of goals do they have with their recovery? So it's just that cohesive effort of working with another team, working with the doctors that do that. And part of what we do too is work on those resources that were discussed earlier. So we help get them connected with 12-step groups or meetings in the area. We'll do that transportation for them. It's just, we understand that there's these barriers that get in the way of recovery, and having a CRS available to be available to do that. Just because we've been down that road, we understand where we can help get them placed. If they're looking for a hot meal, we'll take them to get that at, if there's a, like a soup kitchen around, or they don't have any clothes, they need shelter, whatever it is, working with those partners definitely helps to get these people back on their feet, because we understand that, as I had mentioned before, you're not coming in on a winning streak usually. And sometimes you kind of have to hit a hard refresh to keep going. So with that, I'm going to, we'll move on to Ashley next, but I'm going to check on the questions. And I do apologize about what was going on with this connection. We're going to jump over to the other screen in a little bit. I'm going to look at this chat box too. So Tim, you'd asked, the fine line between needing the legal system or redirection to treatment. Could you reword that? What do you mean by that exactly? If you want to jump on and ask it. face to face.
Like, I think you kind of explained it, but I mean, when like you know, a person gets pulled over, and what's the difference between, you know, obvious, like this person needs to go to jail, or this obvious, you know, this is just like a minor incident and you're going to wreck this kid's life if you try to throw him into the system. Like,
Right. So, and that's always at, that's always at the police officers. No, you keep it plugged in. That's at the officer's discretion. So we do a training with them to kind of give them that idea of like, hey, here's where our services are going to work, and here's where they're not going to work. Just because now if it's like if it's a felony offense, like if it's a DUI, if the person, you know, wrecked a car and wrecked somebody else's property, they're more than likely not calling us. If somebody has like a gram of weed in their car, they can give them that option. And it's up to the individual if they want to accept it or not. They say, hey, here's a charge. I can charge you for X, Y, and Z, or we can call a certified recovery specialist who will meet with you and help you get into treatment. And a lot of times we'll get that call and the person is just stating, I need help. But they don't understand. So that's where we kind of come in to figure out what level of care is needed. So again, that is up to the officer's discretion on that. So let me see. Does that answer it a little better, Tim?
yeah, I mean, like I said, I think you kind of answered it earlier, but yeah,
Right.
it kind of explains it. But it, yeah, it's pretty cut and dry, I guess, that way. It's up to the officer's discretion.
Right. They're not legally obligated to call us.
To reach out to you.
Right, and we, we're doing a training in a week or two with some of the final departments. I think there's 24 total police departments in Lancaster County. Currently, I believe 20 of them are on board. I've met with Chief Anders with Millersville University, and he's aware of our program too. We haven't, so he could realistically call us if he runs into a situation like that. Michelle, I see your question about whether there's programs that exist in other parts of the state. There are similar programs that are being worked on. Our goal with this is really to make it a statewide thing. So once we talk Lancaster County, we'd love to be working in Dalton County and also York County as well. Okay, so the microphone is given an issue, so this would be a great time for me to jump back over to the other screen. Okay. Can everyone hear me okay? Because I think this would be a great time to do a 10-minute break, and then we'll have Ashley rejoin us.
Yes, you actually want that.
Okay, let's do it. We'll do a 10-minute break. I'm going to type it in here as well. So if you're having trouble hearing anything, just to fix the audio. We'll be back at 10 o'clock.
I have been a member of the Blueprints team for a little over 4 years now, and I didn't start off in admissions. Due to being a new company back in 2016, we had a very, very small employee capacity. So I've held various different roles here. And most recently, within the past, I would say 2.5 years, I've been in the admissions department. So it has been, an awesome journey here thus far, just to be a part of a growing program that has made such a massive impact on our community and just the state as a whole. So our main goal here at Blueprints in the admissions department is to make treatment as accessible as possible. We want to make it tangible to anyone and everyone, regardless of any financial capabilities, insurance they may or may not have, maybe lack of experience, fear of stigma, anything along those lines. So at Blueprints, we are licensed to treat men and women over the age of 18. We offer partial hospitalization treatment where our residents reside in one of our transitional living facilities, intensive outpatient treatment, general outpatient, as well as drug and alcohol evaluations. So there are others that will go after me that will kind of delve into all the treatment aspects and the program aspects. I will kind of just touch on them here and there, but I am gonna do my best to focus more so on the admissions process, what our role is, the importance of it, who's reaching out, as well as insurance verification, which is of course the most fun part, and I know everyone wants to learn about. So we'll get started here. So for our admissions process and access to care, we're going to talk about who is reaching out. We'll talk about our intake calls, how people are reaching out to us, whether it's through our website, it's through a phone call, possibly a Facebook message, you know, anything along those lines, maybe an email from another facility, it could be anything. So we do try and make ourselves as accessible as possible. We'll go over our phone screen process, which is basically an over-the-phone assessment, making sure that we are at an appropriate place for any individual seeking treatment. We'll go through insurance verifications, our scheduling of in-person evaluations, any higher level of care referrals, as well as any potential barriers that people may think are real. A lot of times there are solutions to them. I would say 99.9% of the times, any potential barriers that someone sees being in their way of receiving treatment, in my experience, I think someone may have unmuted. Someone unmute themselves.
Yeah.
If you're unmuted, can you just mute yourself again?
Yeah, he's muted.
Okay, cool. Where was I? Oh, potential barriers. So, you know, we do our best here at Blueprints, especially on the front end, to make sure that none of those barriers are existing. So we'll get started here. All right, so who is reaching out? We may be getting reached out to by an individual seeking treatment themselves. During this seeking phase, we may run into patients themselves, family members, you know, it could be anything along those lines. Maybe they have sought treatment before, or maybe they have absolutely no experience in what to expect. And most likely they'll be fairly nervous and scared. I know the unknown, as well as maybe leveling pride or getting honest with yourself and others, could be one of the hardest aspects about seeking treatment. During this time, when we do receive that first phone call, you know, we don't know what's going to be on the other end. And it could be the family member, it could be the employer, it could be another treatment facility where it's their intake coordinator, a case manager, an aftercare coordinator, a treatment marketer, a counselor, anyone from a legal entity. So, you know, we are very highly trained and equipped to be able to provide empathy, as well as additional resources and experience to guide and direct people in the most appropriate direction. So when it is the individual themselves that are reaching out to us, this is one of the most crucial times possible and could be a turning point in someone's life. So on the front end, we do experience on a very high basis
I'm sorry to jump on. We can't hear you again. Or see you.
Okay, we're back to our backup plan. Here we go again. Okay, sorry everyone. Ashley is rejoining us. We are just going to have to go with an alternative approach to this. So, you're on camera. Yeah. We gotta share screen, actually.
All right, perfect. I apologize for that, everybody. So let's see where we were at. So we were talking about that first call that someone may make to us, and where they may be at in their lives. Maybe this is their first time reaching out for help. Maybe this is the 10th time they're reaching out for help. Regardless, it always is one of the most important times in somebody's life and can always be a turning point. So it can take various painful experiences, choices, events, anything along those lines, whether it's internal or external, usually a combination of both to get someone to the point of willingness. And I don't think that that is something that can be given to somebody. I think it's something that happens within. So, when that person does reach out, being on the front end is one of the most important places to be. We can offer a voice of support, comfort, understanding, and reason, regardless of who is on the other end of the line. Let's see where we're at here. So EAP, Human Resources Department, or employers, I do believe that since being in this field, especially in the state of Pennsylvania, that treatment is very accessible here. And a lot of times, like Dave mentioned, is that sometimes you're just not sure how to reach out for that treatment and how to get appropriate care, or to even know where to turn regarding like your insurance coverage or anything like that. So when it comes to the employee assistance programs, HR, or your employer, I find that majority of the time, these entities just want to help people. So if it is an EAP HR employer, they already have their insurance verification ready. They know what their benefits are. They know they're sending them to an in-network provider. So those are always really, really good things on that end of things. And we do find a lot of times too that employers really just want to help their employees. It may be at the point where this person has been given chance after chance, and they do need to set this boundary for them. And in order to set that boundary, they may tell the person, hey, you can go to treatment or you will lose your job. So that's always, something that can definitely be helpful. And to the individual, it may not seem helpful at that time. It may feel like they're being cornered. However, I find that a lot of times it does take some type of outside resource that maybe has to put you in that position to make a decision to get help or not and better yourself. So we'll move down on to any other treatment facilities that may be reaching out, and it could be an intake coordinator where they are on the phone with a potential client and they find that they're not the appropriate place for them. Maybe they haven't used any substances in some time, and they find that our facility would be a better place for them to receive care right off the bat. Could be anything along those lines. Could be a case manager, maybe through CYS or through another treatment facility, an aftercare coordinator, which normally will do exactly what it says, coordinate someone's aftercare. It could be a treatment marketer that runs into someone at a hospital, and maybe the facility they work for doesn't take that person's insurance and they feel that Blueprints is the right place, or anything like that. It could also be a counselor who has known an individual for a long period of time, or maybe just started working with them. And, the counselor could work for a large treatment facility, a hospital. Maybe they have their own private practice, and they do know that this person needs additional substance abuse help. And One other thing I wanted to add that I did forget to put on this list here is when Dave mentioned the recovery homes. So recovery houses are very large in the Lancaster area, all over Pennsylvania, as well as in other states. And a lot of our referrals will come recovery homes, as well as us reaching out to recovery houses to help people continue in treatment, as well as have a structured, stable place to live. Lastly, we do speak to, I would say most commonly, probation officers from any type of legal entity. It could be anything along the lines where someone received maybe a DUI, a paraphernalia charge, possession charge, anything that may have to do or even not have to do with drug or alcohol. And being on probation, majority of the time that I see, you are required to get a drug and alcohol evaluation. There will be others after me that will speak more in detail on what a drug and alcohol evaluation entails, but this is usually the most common place that we will see referrals come from for that reason. There are times when individuals are mandated to attend treatment, whether it be inpatient, residential, outpatient treatment, or just that drug and alcohol evaluation. They may be mandated by a judge, by their probation officer, or maybe they are incarcerated at that time. And in order to be released from prison, they have to have a spot already set up for them in a treatment center that will take them in. They usually do facility to facility transfers where they will be in the jail, prison that they're currently in, and they do need to transfer right to us, no stops in between, usually not able to see any family members or friends. They want to ensure that this person goes directly to treatment and receives the help that they need. I have noticed a lot, along with our second chance program that Dave touched on, that between the different prisons in Pennsylvania, police departments, EMS workers, that there is a very, very high influx of legal entities that really, really want to help people with substance abuse issues. So that's also a very positive change that I've noticed since I've been working here in the last couple of years. So let's see, next. We will move on to one of the ways that people do contact us for admitting to our program or just seeking treatment at all. And that is through our website. We call them online web submissions. They're very simple forms that someone fills out. They can put as much or as little information as they want. There are times when people do not want to be called. Maybe they have a fear of someone hearing them talk about issues they have going on, or maybe they're just not ready to hear themselves speak about it or be honest with somebody to that extent. So they will just put an email address on there, and we can spend months on end communicating with an individual or a family member for months, just waiting for someone to be ready, maybe someone to be released from prison, or a family member gathering the confidence to kind of just reach out to whoever it is, whatever loved one it is that does need treatment. So when we do receive one of these, I would say that our turnaround time of reaching out to someone could be anywhere from like 1 to 10 minutes, depending on what we do have going on. We are available 24/7. So if we receive an online web submission at 10 o'clock at night, we have someone in our admissions team that will reach out to them. If we receive it at 6 o'clock in the morning, we have someone that's going to reach out to them. So with the online web submissions, you know, it is an awesome way to just get that ball rolling and get it started for some people. I know when I first reached out for help, that was the first thing that I did, is that I wanted to utilize a text message or an email, anything along those lines, when I just wasn't ready to express the need for help yet. So it's awesome just to have the different options to be able to just start talking to people, just start that conversation. So our next, let's see. What our phone screen process looks like is, I'm going to scroll through 2 different slides. So, you know, we gather a lot of demographic information. We gather substance use, frequency, the last time, who they are being referred to us by, what's being recommended. You know, we can get calls from pretty much anywhere, anybody. So we have a very, very diligent and detailed phone screen process to kind of get down to every aspect of someone that we could possibly need or need to address. We do have our COVID screening. That is the first thing that we do when someone does call in. So, you know, everything that we ask them, from if they've come in contact with anyone that's tested positive, if they've traveled outside of the state or the country in the last 10 minutes left. Okay. So, you know, if anyone has tested positive or come in contact with anyone that's tested positive, we do require a negative COVID screen before they come in. If they've had any symptoms relating to it, we also require that. And we do schedule them out a bit, at least 2 weeks after any of that has been received. So that, you know, this process does change and evolve very, very often. So everything on here is interchangeable. Sometimes it's done through necessity, just like the COVID screening, not something that we expected to happen. And I know that pretty much all facilities all over the world and nation now have to do this. Let's see our next slide here. We gather our insurance information. There are a lot of times that people aren't aware of what insurance they have, if they hold the insurance, if a parent does, whatever the case may be. So that's also something that we're given the opportunity to help people with, to explain to simplify this process as much as possible. So we go through any medications, if they're coming from another facility where they aren't on any taper while they were there, if they were in detox, any mental health diagnoses, any history of suicidal thoughts, attempts, self-harm, thoughts of harming others. So these are all things that we go through just to make sure that they're receiving the appropriate care, whether it be with us or another facility. Let's go down a little more. We go into some basic things as well as any chronic medical conditions, any allergies, anything along those lines. Just like I said before, if there needs to be a referral out to a higher level of care, maybe someone that's able to treat mental health a little more than we are, as well as assist with any medical conditions, maybe a hospital that is joined with a substance abuse and mental health facility, just to make sure people do receive the appropriate care. Next is the fun part, is our insurance verification. So we are contracted with most major commercial insurance policies. We are also contracted with medical assistance through our surrounding 5 counties of Lancaster, Lebanon, Dauphin, Perry, and Cumberland counties. So the last one here is we're also contracted with the Lancaster County funding. So Lancaster County funding is an emergent resource through the Lancaster Drug and Alcohol Commission, where they have funding set aside specifically for people that do not have any type of insurance, or they just don't have substance abuse benefits through their insurance policy. This is, I want to say, one of the greatest and most helpful things that could be offered within the state of Pennsylvania, where, you know, anyone can seek treatment. They do work based off of a sliding scale. So they go based off of claimed dependence and claimed income. And pretty much, you know, if someone were to come into our care, they would have very, very little cost for treatment, not something that's expected to be paid up front. You know, one of the greatest things about Blueprints is we do offer very, very flexible payment plans, and we do make it as accessible to everybody, regardless of their financial situation. One of the last things we have here is just scheduling our evaluation. So this is one of the last steps in our admissions process. So when we get to the point that we're ready to put them on the schedule, we do go over our COVID screening again. We answer any program questions that someone may have, you know, especially if this is a new process to someone. You know, there may be a lot of questions. There may be a lot of language that they don't know or understand that is very common to us, being that we work in the field. And we also do an intake intake overview. So at this time, we will go over their insurance benefits, their coverage, if there's anything out of pocket that's needed when they come in for the evaluation, and what they can expect if they do get recommended treatment. So during this process, we also go over transportation, which I forgot to mention on here. So one of the cool things that Blueprints also offers is transportation to and from any group counseling, individual counseling, as well as drug and alcohol evaluations. We find that that is one of the most beneficial aspects that we can offer the community, being that majority of people may not have a license, may have gotten it revoked, may not have access to public transportation or a car. So, you know, that's one of the most advantageous aspects of the accessibility of our treatment over here. What I mentioned before during the intake process is possible higher level of care referrals. So this could be anything along the lines where maybe someone is actively drinking alcohol or using benzodiazepines, where the withdrawal factor with them is very, very high, and is not something at Blueprints that we're able to treat, where they may require hospitalization, medical detox, where they are being observed 24/7 by a nursing staff as well as a doctor. Maybe they do require inpatient care, or a referral to mental health or crisis, where they will be in contact with trained specialists to make sure that they do receive the care that is most appropriate for them. And then lastly on here, I do have potential barriers that someone seeking treatment may try and use, which they do seem very, very real, but there are solutions to every single one of the barriers that someone may think that they will face. So the first one that we have here is fear of the stigma. Maybe they think that they're going to be judged by others, maybe not have the support of family members, have the fear of being judged as a criminal, whatever it may be. I know for myself, I had that for a long time, and that's something that kept me from receiving help. I think one of the most awesome aspects that I know Dave touched on as well is the support of the community. So in all of our programs that we offer here, they are very community and peer based, as well as the option and the availability and accessibility of different outside entities, recovery support networks, 12-step networks, anything along those lines. It could be a church, anything like that, where they are focused on the community aspect and having peer support. Next, we have the willingness of the individual. And like I said earlier, that willingness may come from an intrinsic inside part, or it may come from external factors, maybe legally or family, or a spouse, maybe children, anything along those lines. Then we have insurance coverage, out-of-pocket expenses. And like I mentioned before, we do make our treatment as accessible as possible, being contracted with most major private insurance companies, medical assistance, county funding, as well as we do take self-pay, and we have very low self-pay rates and flexibility when it does come to any out-of-pocket expenses that may be needed. Someone may also be worried about their job security, worldly responsibilities. Maybe they're a parent, maybe they have rent to pay or a mortgage to pay, transportation aspects, where with all of these things, there are things that back us up in the state of Pennsylvania, like FMLA, short-term disability, maybe just being honest with your employer, getting help from family members. These are all things that are accessible here. Regarding the transportation, us as a facility, as well as every facility that I know of, does provide transportation to get people to and from treatment. Maybe they have outstanding legal obligations. These are also things that once someone enters into treatment, they get with their counselor, and they're able to work out with maybe their probation officer or a judge to extend a hearing that they may have, get things pushed off a little bit, or maybe attend them while they're in treatment and they have the ability to say, hey, I'm receiving the help that I need, and I'm still going to show up for my responsibilities. Could also be anything along the lines of any medical needs that they may have, where they can enter into facilities that do give them the treatment that they need medically. And lastly is availability, where there could be times where someone's trying to get into treatment for weeks at a time and they keep saying that there's no bed availability. This is something that I do see happen out there, and we do our best as a facility, if we do need to make a referral out, to stay on top of that and make sure someone definitely receives the treatment that they need. I believe that that is the end of what I have going on here. And I am 100% open to answering any questions. All right, thank you guys so much for your time.
Hi, everyone. My name is Brooke Sauer. I am the billing manager here at Blueprints. So the first thing I want to go over before really getting into the presentation that we have here is just really going over how intertwined our departments are. So the billing department heavily relies on admissions and clinical for a lot of reasons. And that's something that I really love about this company, is that we work together as a team, because that's how we function, and we do it in a way that really gives our clients the best support possible. So the first thing we're going to go over, these are the different bullet points that I have here. One is understanding insurance benefits. The next one is going to be patient responsibility, billing insurance claims, following up on claims, and billing patients. So the first thing is understanding insurance benefits. This is really important because even though we are just billing, we have to understand if a claim is properly processing the way the benefit was verified. We have clients that call in and they have questions about explanation of benefits that come in, and we have to be able to give them detailed answers. Also, transparency with our clients. A lot of the times somebody comes in, they really want to know beforehand what they're going to owe. So in our patient responsibility, the first thing that we do, not only does the admissions department go over the insurance benefits with the client before scheduling their evaluation, but after their evaluation, something that we do here at Blueprints is, once they are determined a level of care and it's chosen that they're going to be getting care with us, we will go over what their insurance looks like. What is their copay going to look like? Co-insurance. And every single insurance payer, there's a different contract. So it's really important from a billing department standpoint to be able to give a client those numbers. It allows them to know what's going on, feel more comfortable with the process. And like I said, the transparency helps them. The next thing in regards to patient responsibility is collecting deductibles, copays, co-insurances. With that, we are responsible, contracted with these payers to collect all of these cost sharing that they have. Now, as a company, the one thing that I really love is something that David mentioned was I was working with Chris in the recovery houses, and we noticed that there was a need. There was where people were being denied treatment due to affordability, insurance. And something that I love about this was we were able to create a flexible billing policy for patients to ensure their access to treatment. So with this, it means, yes, we do have to collect deductibles, co-pays, co-insurance. However, we have the ability to do this in a more flexible way so that the patient can put their treatment first. It's not where they have to miss a session because they don't have a copay. We understand that a lot of the times when somebody is stepping down from a level of care and going into a recovery house, that means they have rent. That means they have to provide food for themselves, things like that. And they're trying to find the balance of life. So with that, we had to recognize the fact that if we don't put our patients first and their financial needs, they're never going to get the treatment that they need. So it was really awesome to be a part of that experience of going through our contracts with our insurance payers and making sure that we were able to stay in good standings with them, but at the same time, make this so accessible to our clients that they're comfortable with the treatment no matter what their insurance is. Once a client is with us, we start billing their group notes. Now, a way we do that is we have to rely, let me click here into the next slide. We have to rely on our clinical supervisors for this, especially during COVID. So one of the big things that have changed is that with COVID, we're doing a lot of telehealth services, but there are services that we can provide face-to-face. So in order for the billing department to know what needs to be billed telehealth and what needs to be billed face-to-face, we really do have to rely on our clinical supervisors to be checking these notes and making sure they're accurately marked. One of the things that we are able to do as a billing department is we check the patterns of the group notes. We know certain days for certain clinicians, there's supposed to be certain notes. So checking those patterns, we're able to see if something is missing. So that's something that we have to do on a regular basis, is go through that in order to make sure everything is being billed correctly. It's not marked as the wrong date, so on and so forth. Another really important thing that has changed and has been something that we've had to pay a lot of attention to is keeping up with the payer bulletins and updates, because now with COVID, a lot of the different payers are, continuously changing what modifiers being billed with, what place of service is being billed with, their expectations. And this also falls really a lot on the admissions department, is knowing if this client has the benefit for telehealth services, and then what we can do if they don't have that benefit to be able to still provide care. And that's what's great right now, is where we do have certain services that can be face-to-face, is being able to provide different options for clients. Next, we have following up on claims. So the first thing is, when you're following up on a claim, you're making sure that they're processing accurately based off the verification of benefits from the admissions department. Once again, a huge way as to why we are so connected with the admissions department. We rely on them to make sure that this information is clear and detailed. What's great is, for myself, I came in with Blueprints opening. Like Ashley, I played many different roles and wore a lot of hats here at Blueprints. So one of the things that I was able to do was I was a part of the admissions department. So it was an easy transition for me coming into the billing department and already knowing what the benefits are, what they look like. So that was definitely something that was helpful. Understanding our contracts with payers. So a lot of times we will find with claims reps that they don't see the content of our contracts. They can't see it at all. A lot of times it has to be escalated. So in order to ensure that a claim is processing accurately, you really have to understand your contract and how it's written out, so that you have the ability to provide this information so that it can be escalated beyond just the claims rep to be able to get processed. Another thing is knowing your state laws, what's allowed to be shared and not allowed to be shared with the payer. Oftentimes you're going to find that the payer is asking you for something that you are legally not allowed to share, and you have to disclose that. There's times where I've had to print out and send state laws because I'm not going to cross those boundaries from a legal standpoint and ethically. The contents of a group note don't need to be shared with the payer. At the point of the utilization review is where they determine medical necessity, and at that point, that's where they're determined whether or not this treatment is needed. Also knowing when it's appropriate to send an appeal. So something that's important with the appeals process is it's a last ditch effort. So you really have to know, because oftentimes you're told, oh, send an appeal, and you know that you have more room in regards to who you can reach out to try and get these claims processed before sending an appeal. Knowing what is actually appropriate for an appeal and what isn't is very important. So the last thing that we're going to go over is billing our patients. So following our policies and procedures, invoices are sent to our clients. What is something that we typically do is anything that is on our client's ledger in regards to a balance, typically after their claims have all processed, we'll send them an invoice. We also give them a courtesy call. We understand that some people don't have email addresses for these to be sent, so they're being sent by mail, and some live in recovery houses, but their address isn't updated and it's still at their families. So we're really providing them with as much access to this information as possible. It's something where we send multiple invoices out for each patient over a period of time. Like I said before, we are legally responsible to collect patient responsibility for these claims. So it is something where we can't just turn around and say, you know what, you don't have to pay this right now. So it is hard for some patients, but having the ability, like I said, to create the flexible billing policy has really made it easier. And we have seen a huge difference in patients' ability to continue to come to group. So that's something that, we're really happy about. At this point, I don't have anything more in regards to our billing. Is there any questions that you guys might have?
Okay. We're actually going to be joined by Dan Hambleton next. He's our information technology director. He's just going to talk briefly about telehealth implementation. Originally, when we were asked to do this training, one of the things that we were going to touch up on was telehealth. And Dan is doing this remotely. And Tim, I did see you wrote on there about how important the financial support is during recovery. And it is, just kind of, it might seem weird that, we have people talking about billing and, the topic being the continuum of care, but, it's just showing all the inner workings, and this isn't this is very common throughout the treatment field, knowing that this is for OEP, the Opioid Workforce Expansion Program, knowing that one day a lot of these students, we're hoping one day that we may see you working side by side with us. We're hoping that we're able to get across to you how important it is, some of these things that are behind the scenes. So such as the billing aspect, the admissions process, and now what Dan's going to present, the telehealth implementation. So what I'm going to do is I'm going to turn that over to Dan now. I'm going to mute myself here. And Dan, you're up. Thank you.
Good morning, everyone. As Dave said, my name is Dan Hamilton. I'm the Information Technology Director for Blueprints. I've been with Blueprints for about 2 years full-time, and prior to that had provided IT services on a consultant basis. But like Dave said, I'm going to be going over telehealth implementation. So back on March 18th, the Office of Mental Health and Substance Abuse Services had announced the loosening of requirements for offering telehealth services. And on March 19th, the next day, all of our outpatient and intensive outpatient services were exclusively delivered via telehealth. So as you can see on the screen, I broke this out into 4 segments, but I'm going to use that experience as a way to, explain and demonstrate what we did to implement telehealth. The first thing is tech requirements. So obviously computer, webcam, microphone, speakers, it's pretty straightforward. But one of the things that we ran into was it turned out webcams, because of the pandemic, were on the level of toilet paper in terms of scarcity. So we had to scramble to get together enough devices for our counselors to facilitate their groups the next day. And as the supply chains caught up, we were able to procure some webcams and speakers and get into a more ideal setting for with our hardware. Most of the webcams, they have a speaker embedded, or I'm sorry, a microphone embedded, and a lot of the computers have speakers embedded as well. One of the things that we ran into was the regular desktop computer towers. With telehealth, we found that the audio level and quality wasn't sufficient, so we ended up buying some external speakers that plug into the computer for the counselors to be able to hear the clients better. Also, a lot of people prefer earbuds. A lot of computers nowadays are Bluetooth enabled, so the little wireless Bluetooth earbuds are also pretty ideal for facilitating group. And for software, that was one of the biggest decisions that I had to make on the fly for switching to telehealth is what platform we are going to run our sessions on. There's a bunch of video telephony or video conferencing platforms out there. At the time, prior to the pandemic, Zoom had actually been in the technology news quite a bit for security issues and security vulnerabilities, which is pretty unfortunate for them leading into the pandemic and a world relying so heavily on video conferencing software. To the best of my knowledge, they have addressed all of those concerns and is a reliable and secure platform. I reached out to some colleagues that were using another platform called Blue Jeans, which I was not as familiar with, but one that is had been tried and true in my career was GoToMeeting, and I took another look at them that day while we were switching, and they had a whole table listing HIPAA compliance standards and what they do to address them. I was happy with their encryption protocols, and they had they're willing to sign a business associate agreement, which is required for HIPAA compliance, especially with if you're recording any sessions, and I'll get into that more in the last segment. But so anyway, we went with GoToMeeting, which is now owned by LogMeIn, as the platform we use for our telehealth groups. The next requirement is IT support. On a good day, I don't get any support requests from our clinicians, for the telehealth services. In the beginning, that wasn't the case, and I'll go over that more in the staff training segment. But one of the other things to consider is internet speeds. Sufficient internet and reliable internet in order to have like a consistent connection. for the telehealth groups. And we ended up adding some more wireless access points in that area of our building. What was sufficient for day-to-day use wasn't when, when you have a bunch of telehealth sessions in progress, that is a lot more heavy on the internet load than just like regular web browsing. And then as far as cost goes for implementing telehealth, this is the section where you find almost all of that. The hardware, is usually going to be like a one-time upfront cost. And then most of the video conferencing platforms are based on a per person or per clinician cost. And those range, in the like $15 to $25 a month range. And then the cost of, having IT support. The other thing to, consider is, the cost in switching to telehealth with client engagement. And, we found that a lot of people actually, had preferred the telehealth, and we had really good attendance. I haven't heard, as of late, but we kept a close eye on that when we were switching, and we didn't know what to expect, but it actually went really well. So for staff training, I would say this is extremely key in having a smooth, uninterrupted groups. The counselors are already facing a challenge with telehealth and quality of care and client engagement. So to have technical difficulties or navigating a new platform on top of all of that can be nerve-wracking and overwhelming for the clinicians, especially in our case, because we switched overnight. There was a little trial and error with that, but that the morning prior to kicking off telehealth, we all met in the conference room and we went over the platform and how it works, how to use it, what the different features are. And at that time, we had some staff that had never used or facilitated a group from or a virtual meeting from something like Zoom or GoToMeeting. And here we are months later, and so much of the world, it's like it's an everyday thing for us now. But it was definitely a bit of a learning curve for some of us. And like I said, we ran into some issues along the way with the sound quality and the internet speeds, and I would say like within the first month we had that all ironed out, and it's gone very smooth since. But definitely training and having more sufficient time for that is key in order to have smooth groups. And for policies and procedures, that some of that kind of took shape along the way. There were some things that we had to consider up front. It's tempting to keep the same meeting ID for each counselor because of convenience and for the clients having to connect every day. But for security reasons and the at clients' discharge, we get new clients every day. So we thought it was important to have a new meeting ID for each session. So what our clinicians do is they go in every morning and they create their meeting ID and pass that along to the office manager, who then communicates that to all of our clients that are expected to be in group that day. And some of the other things that you wouldn't necessarily think about are with them attending group remotely, things like signatures. I believe OMSA had said that at least for that first day, to request from each client verbal consent to treat via telehealth, which we do. Currently, we do all of our evals one-on-one in person, and so we're able to get those signatures from them at that time while they're here at the facility. But we are looking into DocuSign and should be actually rolling that out in the next week or two, where they don't have to come in at all, and we'll just get their signatures electronically. Another thing that had come up was UDS, urine drug screens. That's something to consider where, you know, before they were coming to the facility every day. So that was, you know, easy to manage, but you know, it's something to consider if they're never coming into the office, as it's of course you know, a measure of success in response to treatment. And the other thing is having the clinicians working from home or in the office. You know, there's definitely some considerations there when developing your policies and procedures for telehealth, and just qualifying, you know, their own devices and their home internet, and you know, how they're going to get support and how that impacts their collaboration with other clinicians and supervisors. For HIPAA compliance, the main consideration for telehealth is, of course, the platform that it runs on. You know, it's cloud-based. It's not something that is in-house for us. So, you know, like I was saying, in vetting all of the different platforms, you know, remaining in compliance with HIPAA standards was extremely important. And you know, if you do a Google search of any of these platforms, they all have you know, web pages dedicated to compliance and how that relates to HIPAA, and some of the platforms even have different licensing models for healthcare providers, and some of that is way outside the scope of what we need it for you know, to do IOP groups, but considering your need, that is definitely something to look into, is the different licensing models and anything that they have geared directly toward healthcare. And the business associate agreement is extremely important if you're going to do any recording, because that is stored by them, and with that comes protected health information that is in their hands, essentially on their servers. So you know, that's an absolute requirement to remain in compliance. We do not record our sessions or save them, you know, in the cloud or anything like that. So you know, my main focus was the encryption and platform security, and you know, to make sure that everything that they do on their end remains in compliance with the current HIPAA standards. Let me make sure I didn't miss anything. I think that's about all I have. It was a pretty niche topic, so definitely open to any questions that that everyone has, you know, about telehealth.
And as a reminder too, if anybody has questions that may come up later, we can always, we can give you people's email addresses. If you have questions for particular speakers, it may come up later on. If they're not available in the office, we can always do that. We can definitely facilitate that.
Absolutely. Yeah, Dave, happy to put that in the chat, or if, you know, if anything comes up, feel free to give that.
Yeah, we can share that with everybody. All right, so thank you, Dan. I do appreciate that, and honestly, a lot of what we're doing today, I think our team is really learning a lot too from this, and just seeing the full scope. We're actually going to be joined next by Melissa Callahan. She is remote right now, so she's in her office. I'm just going to have to check in with her, so just bear with us for a second, and we'll get to that shortly.
Can you hear me?
Yep, we can hear you, Melissa. Are you?
Oh, good.
Are you good to share the screen, or do you need me to do it on my end?
No, I think I'm good.
Perfect.
I think I already had it ready. Let me know if you can see everything. Can you see it?
Yep.
Okay, perfect. So do I have to give any introductions? Am I good to just start, or where are we at? Who's all here? Are there a lot of people on?
Looks like there's about 80 people here.
Okay, great.
I'll have them send questions to me.
Okay, good.
Melissa's going to take us up to about 11:30 on withdrawal and detox. So I know it's kind of a lot for you to do real quick here. Melissa's also rejoining to discuss MAT and harm reduction after that. So if there's questions that may come up for Melissa, just send those to me in the chat, and we can also discuss anything after she's done as well. And Melissa, there's going to be some nursing students joining around noon.
Okay, so there's no one in nursing or medical on right now?
There's some people, I believe there's some with medical right now. Yep.
Okay, great. Great.
And if you have a camera that you want to turn on.
Yeah, it looks like it doesn't want my camera to go on right now, which I don't want to waste our time doing it. I can work on that after this part and make sure that it's all up and ready for the next one, if that's okay. Is that fine with you?
That's fine. Yeah, that's why we have your picture there, so everyone knows who's talking.
Okay, good. All right. Hello, everybody. And withdrawal is it's pretty intense, especially I want to go over alcohol, benzos, opiates, and some of the typical presentations of withdrawal. My name is Melissa Callahan. I'm an adult and geriatric nurse practitioner. I've been working in primary care as well as the behavioral health field for 20 years now. So I've become pretty passionate in behavioral health, substance use disorder specifically. This is a PowerPoint that I had created for nursing, for therapists, to just really go over the quick and dirty of some of these disease processes that we are dealing with, and just to give some information. There is some overlap, but it's good to just kind of know what you're dealing with the people that you have in front of you. So I am going to go through this quickly, and I'll read through it quickly, and then I want you guys to be able to have break. But questions, send them through. I'll answer every question that you possibly have, because the point is that you actually walk away taking something with you and having questions answered. So I would like to start talking about acute withdrawal. And the definition, simply, it's the initial emergence of symptoms that begin after suddenly discontinuing a use of substance. I like to go over the typical length of an acute withdrawal quickly. Now, obviously, every case is different, but in general, alcohol generally is 5 to 7 days to present in acute withdrawal. Benzodiazepines are more like 1 to 4 weeks. And if you're going to actively medicate people from benzos, it could be 3 to 5 weeks of reducing dosages to get someone through the acute withdrawal period. Opioids are generally 4 to 10 days. Methadone and even fentanyl recently is closer to a 14 to 21 day presentation. Cannabis is 5 days. Nicotine is 2 to 4 weeks, which I think is really important because some people minimize withdrawal from nicotine, and you can present with a lot of symptoms. And I go over them very briefly on one of the last slides. Stimulants are generally 1 to 2 weeks as well. So this time frame describes that symptoms last beyond that. This is your acute withdrawal. And then the symptoms that last beyond this point, we used to call it back in the day protracted withdrawal. More commonly, you hear pause or post-acute withdrawal. Sometimes you'll hear chronic withdrawal or extended withdrawal. And so we'll just focus more on acute withdrawal, but I will discuss all the presentation symptoms that you can observe. So we'll start with alcohol first. Typically, people present with hypersensitivity, and that's hypersensitivity to light, to sound, anxiety, tremors, sweating, nausea, elevated heart rate, increased blood pressure, fever, which is probably one of the most important symptoms in a medical environment, and I'll talk about that a little later. Hallucinations and delirium tremens, or DTs, generally occur in more severe cases when people are not being medically managed. Alcohol is one of the use disorders that requires medical management because death can actually occur, but extreme neurologic abnormalities like hallucinations and DTs can occur. DTs are in less than 5% of individuals, and it tends to be people who are not seeking medical treatment. Obviously, withdrawal symptoms are going to be different from patient to patient. Some of the factors that affect the severity of withdrawal is going to be the severity of dependence. So people who've been using more, longer are going to have a more difficult withdrawal. The amount of drug, the amount of alcohol that they're using will also affect how hard the withdrawal symptoms are. Illicit drug use mixed, especially benzodiazepines, but any mix really with alcohol is going to have a more severe presentation. And then any coexisting medical conditions. So if they already have an infection, a history of endocrine problems like low blood sugar, diabetes, history of seizures, they will all cause withdrawal symptoms to be more exaggerated and become more severe. This is a timeline. So the next couple of slides, I talk about timeline. I talk about typical presentation. I have a slide that will have everything just in writing, which is kind of boring. And then I like to use pictures because a picture stays in my mind and I'll remember longer. So I just use more than one option because people sometimes want to take these slides after so they can just have them, something to reflect on. So a typical alcohol withdrawal timeline. You will begin to see active withdrawal 6 to 48 hours after the last drink. So it can begin, most importantly, people should know, it can begin when you still have a large amount of alcohol in your body. So people who are used to drinking large amounts for consecutive periods, they can have a positive BAL 0.2 and be an active acute withdrawal. So that's important to be aware of. 5 to 7 days is kind of the sweet spot with alcohol where you're going to have your most complications. You'll have mostly the elevated heart rate, restlessness, that's your central nervous system becoming reactive to not giving alcohol. GI symptoms like nausea and vomiting are pretty typical. In this acute withdrawal period, it's the most dangerous, as I said before, because people can experience a seizure or DTs if they're not under medical management. Temperature elevations as slight as 98.9 can sometimes be the first symptom of DTs or impending seizure. Most seizures that occur during withdrawal is because your sodium level drops. So it's a presence of dehydration. And a lot of people think of dehydration as you haven't drank in a while, but when someone is an alcoholic and they're intaking so much volume a day, any reduced volume from that usual amount is already a dehydrated state. So in the detox setting, it's not typical, the presentation. So dehydration can occur that first day just because they're not intaking that volume of alcohol that they would have normally put in their body. What I also think is pretty interesting and people are sometimes surprised about is that protracted withdrawal or chronic withdrawal can occur for up to 2 years after your last drink. People don't realize that symptoms of depression, fatigue, concentration issues, the number one that I think I hear the most is insomnia, can actually occur for up to 2 years after your last drink. There are technically 3 stages that they speak of when they talk about alcohol, and stage 1 is your preliminary stage. It's usually occurring the first 8 hours after not drinking. You're going to see obvious symptoms of shakiness, GI symptoms, abdominal pain, nausea, vomiting, fatigue, muscle weakness, depression, loss of appetite. This is just a picture view that I like to have. Like I said, this is how I remember things a little bit easier, but this is what you're looking at in the first alcohol withdrawal symptoms. Stage 2 is generally, you're going to notice more of your central nervous system reactions, which is going to be your increase in blood pressure, your increase in your body temperature. Like I said, a temperature of even 98.9 is a first indicator that you either have to start medicating a patient, if they're in the medical setting, really watching the patient pretty closely. You'll also see mood swings, anxiety, irritability, changes in breathing, the breathing patterns, which occurs from your central nervous system. Stage 2 quickly follows stage 1 and generally starts within 24 hours after that last drink. And these symptoms, along with the ones in stage 1, can last up to 72 hours. It depends on the individual's degree of abuse and volume that they're used to taking in. And here's my nice little picture slide of stage 2. And then we get into stage 3. And the hope is that in most programs and good programs, you're never seeing this. And hopefully patients are actually seeking treatment so that they are not seeing this. But in stage 3, you can see seizures, tremors that are really severe in the high levels of, if we grade it out of a grade 7, it's going to be in your upper 7 out of 7. Confusion can begin, lack of focus, delirium, hallucinations, which are generally visual, not as much auditory, although that may be present. DTs is often described. Patient presents with an elevated temperature and they feel like they're seeing squiggly lines or bugs. Usually it's like bugs or rodents. They either see it on the ceilings or walls or on their own skin. People will present with restlessness, agitation, increased activity, just movement. And they can also have deep sleep. So these stage 3 symptoms, they don't necessarily follow stage 1 and 2. Sometimes they can occur within 12 hours of your last drink if somebody is a very, very heavy drinker, or they have the comorbidities of another medical problem associated with it. And people really should be in a medical setting and treat it medically to safely come off of alcohol, because it can be life-threatening, as I said before. And then this is my little picture I like for stage 3. And then your post-acute technically is 48 hours after and lasts up to the 2 years, like I already talked about. And sometimes it's really mild symptoms like depressed mood, decreased energy, difficulty with sleep, decreased metabolism. So medical complications, and we've kind of gone over these, but this is why it's considered medical treatment is required for alcohol, whereas when we talk about the rest that comes after this, opiates and beyond, it's not considered, especially with insurance companies, as serious. So the worst case scenarios is you can have a seizure, you can experience DTs, you can have a very unstable heart rate, body temperature, and blood pressure. Patients can experience hypoglycemia or low blood pressure. With excessive alcohol use or chronic alcohol use, you can see GI bleeding. You can have hepatic or liver failure, cardiomyopathies and cardiac dysfunction, pancreatitis, and encephalopathy. Like I said, you may have questions, but because I have to really go through a lot of stuff, I'm going to move on to benzodiazepines. I think it's important sometimes to list some of the trade and brand names of medications. Some of them are really old, some we haven't used for a long time, but benzodiazepines are all man-made medications, and they can cause mild to severe depression of the nerves within the brain. So the central nervous system, like I talked about earlier, and generally the end result is they'll create sedation and drowsiness. Benzodiazepines have been around for a really long time. They were used as muscle relaxants. Originally, the elderly population received a lot of these medications. Nowadays, a lot of our young kids are really abusing a lot of benzodiazepines. I'm not going to go through the whole list, but this is the most common benzodiazepines that we're using in the United States, and some we're actually not even using anymore. But I would say most recently Xanax, Klonopin, probably the most common that I'm hearing. Ativan, Ciarex, Librium, you're seeing that more in the hospital setting, but in the use disorder, you're seeing pretty much Xanax and Klonopin. Klonopin is one of the benzodiazepines that you will not see on a typical urine drug screen. So it will come up negative. And so a lot of people will use the Klonopin because they know they can get away and not have their drug screen come up positive by utilizing it. Adult men and women use benzodiazepines, the multiple diagnoses that you could use them for: anxiety, nervousness, panic disorder, muscle spasms, seizure disorder, sleeplessness, alcohol withdrawal, status epilepticus, premenstrual syndrome, social anxiety disorder, and panic disorder. Other uses, it's used during sedation with surgeries oftentimes, and the most common anxiety disorders are generalized anxiety disorder and post-traumatic stress disorder. Common side effects of benzos, there are ones that overlap pretty consistently with alcohol because they do go to some of the same centers in your brain. Lightheadedness, drowsiness, confusion, sedation, memory impairment, improper body balance, increase or decrease in your appetite, nausea, vomiting, constipation, weight gain, dry mouth, reduced libido, and fatigue. Serious side effects of benzodiazepine. They can cause some pretty severe respiratory depression. They can lead to dependence and abuse. They can also lead to withdrawal symptoms. You can become jaundiced. You could have seizures. There's risk of suicide, slowed heart rate with potential very low blood pressure, fainting, akathisia, and increased heart rate. So with benzodiazepines, when somebody is withdrawing, I always say, being in the industry for 20 years, and some people look at me and don't really understand, but benzos are one of the hardest things to come off of. They're one of the hardest detoxes that I notice, because people become very used to them. And this slew of presentation I'm going to speak of can actually last really long, months and months. Benzos, generally, you're doing like a 14 to 21 day taper if you're really bringing someone off correctly. If you're lowering them in the outpatient setting, 3 to 4 weeks minimum. But I say there's a minimum of 3 to 6 months before you really start to see improvements in a lot of the withdrawal presentation, which includes difficulty concentrating, insomnia, irritability, increased anxiety, tension and sweating, panic attacks and shortness of breath, hand tremors, dry heaving, vomiting, dry mouth, palpitations, headache, muscle pain and stiffness, body pains, decreased muscular control. There's a lot of perceptual changes, visual changes like double and blurry vision, disorientation and hallucinations, fevers, chills, nausea, and diarrhea. So, benzos were used very, I'm sorry, can you hear me? I just got a little background there. We okay? Okay.
We could still hear you. You're good.
Okay. All right. I'm going to keep going. There was like a little background, so I didn't know if something stopped there. But benzodiazepines are very difficult to come off of. You saw the litany of diagnoses of why people have prescribed them in the past. That people become dependent on them very quickly, and mixing them with something like alcohol really leads to detrimental outcomes. It's like one of the highest causes of legal issues because people black out and they don't even know what they've done. So it's a pretty lethal combination, and those drugs were prescribed pretty loosely for years. And thankfully in the past 5 to 10 years, we've gotten a much better hold on it, which I think, has made a huge difference. So let's get into opioids, because this is all we ever hear about anymore. We're in the middle of an epidemic, even though the pandemic is somewhat covering it and we can't see it so much. I think it's important to talk about some basics about opioids that people don't quite know. So I just like to get a little bit of education out there. The common opioids that I see often that are prescriptive, I listed them just in increasing strength. So codeine is considered a very low level opioid. Hydrocodone, which you may see in the names of Vicodin or Vicodin, is next. Morphine, which you may see MS-Contin and Cadian. Oxycodone, which you may see as Oxycontin or Percocet. Hydromorphone, which you might see as Dilaudid, and then fentanyl, which is often used in Duragesic. I think it's important to realize that there are 3 different kinds of opioid drugs that exist. There are the natural drugs that are derived from the opium plants. So it's from opium poppy, and the plant and the milk that comes from the plant and its seed pods is what is utilized to create drugs. There are synthetic, which are 100% man-made. They're manufactured in a lab and they have no natural source to them. And then there's the semi-synthetic. So they use a little bit of natural and a little bit of synthetic. So your only natural opioids that exist at all is opium. And you won't see opium nowadays on medications that are created. You're going to see thebaine, and I will talk about what we see that in nowadays. But thebaine is a natural opiate that occurs in the poppy plant. The only other 2 natural opioids are morphine and codeine. So anything else that is out there has been created by man. So your pure synthetics, which have no natural or normal in them at all, is Demerol, which is meperidine, fentanyl, and methadone. Your semi-synthetics are buprenorphine. So buprenorphine is actually derived, its natural components derived from the thebaine. Hydromorphone, which is derived from morphine. Oxymorphone is also derived from morphine. Hydrocodone is synthesized from codeine. Oxycodone is modified from theanine, and heroin is synthesized from morphine. So opioid withdrawal, a lot of the same symptoms that run with alcohol and benzos because of how much it satisfies the central nervous system. So there's irritability, anxiety, fatigue, insomnia, and then some very specific to opioids are your muscle aches or myalgias, your pretty severe GI symptoms, nausea, vomiting, diarrhea, fever and chills, sweating, runny nose, and teary eyes. Oh, yeah, okay. And then the last couple slides that I threw on here are cannabis withdrawal. A lot of people don't believe that using marijuana has any withdrawal and, you know, it's supernatural plant. But it is important to know that it's still a Schedule I drug. It does have addictive properties to it. The body does become tolerant and dependent. And if you stop using, you will present with symptoms of insomnia, loss of appetite, anxiety and tension, depression, nausea, fatigue, night sweats, nightmares or strange dreams, and headaches. The next one is nicotine, which I just want to go over again. People also think, you know, you can just stop quitting and it's just about, you know, being irritable, like that's really the only presentation. But nicotine withdrawal is pretty severe, and people, the longer they've been smoking, the more they've been smoking, the more severe the presentation is. So cravings, which are obvious, irritability, which people talk about, but people can actually get to like an irrational rage, which is how Wellbutrin was rebranded as Zyban as a tobacco cessation drug. Because what Wellbutrin does the best is it really helps treat that irritability. Other withdrawal presentations include anxiety, depression, weight gain, dizziness, and headaches. And people who have smoked for a long time, it's really prolonged. So the acute phase might be within a week or so, but you can have symptoms for quite a few months. So it's really difficult to come off of nicotine. And the last one, I just want to go over the typical presentation symptoms are of stimulants. So the typical presentation is going to have depression, oversleeping, increased appetite, anxiety, slow thoughts, slow or lack of movement altogether. So that wraps up most of the withdrawal presentation and typical symptoms and a little bit of time frame. We have a couple minutes. Are there questions that people want to go over now?
Hey, Melissa, there was a question somebody was asking about PCP.
Yes. So the presence of withdrawal, or what's the specific question about PCP?
Just asked if there's any information on PCP. So I guess.
So unfortunately, PCP is very synthetic created. So there's not a lot of natural substance to it. And unfortunately, it's mixed with so much stuff nowadays. What I find most often from PCP is it actually acts, its withdrawal presentation is often much like stimulant withdrawal, but probably what we see the most is psychosis, presentation of hyperactivity, and definitely hallucinations. People definitely lose time. That's often described with PCP. There's no really withdrawal treatment that's utilized for PCP right now. And like I said, unless you really break it down and find out if it's just PCP, because a large amount of marijuana now is mixed with PCP. I have a lot of families coming in who are drug testing their teenagers and not understanding why they're so crazy. Teenagers are saying they're just smoking marijuana, and then they're finding out that there's a lot of laced PCP within the marijuana. But there's nothing medically usually given for PCP. Sometimes they'll use benzodiazepines or a barbiturate to just slow the central nervous system and try to slow, the weaning out of your system, because usually it's irritability and hyperactivity and hallucinations that occur.
Okay, there's another question asking if withdrawal symptoms are more severe for older individuals and what would be the best treatment option for them to assist in withdrawal.
So definitely there is a difference of withdrawal from every drug dependent on age as well as comorbidities. And as you get older, you tend to have comorbidities. So your 18 to 25-year-olds tend to get through most of the detox processes pretty quickly because they don't often have comorbidities. But as you get older in age, everything seems to take longer. Everything is definitely more exaggerated. So all the same presentation, but exaggerated. We will use different medications specifically for alcohol and benzodiazepine when we are detoxing people. Like, for example, for alcohol withdrawal, if you're over 65 or you have elevated liver functions, or if you have a history of withdrawal seizures, we would use Ativan, which is a longer acting benzodiazepine, whereas the average person coming off of alcohol and benzos, we tend to want to use a barbiturate like phenobarbital. But phenobarbital lasts a really, really long time in your system. And if you have a compromised liver, it's definitely not the best choice. So medications do alter based on your age. The comorbidities that you have along with your drug of choice definitely will alter how we monitor you. And pretty much every withdrawal symptom seems to be more exaggerated, take longer. The younger they are, they seem to accelerate through most of the withdrawal presentation a little bit quicker, and they have less needs. Hydration is really important with the older, and older, I mean almost anybody over 30. It's kind of like the under 30 population, then over 30. And then when you really get up to over 50 and 60, you just have to be so aware of the comorbidities, because if you're using for that long, you generally can't get away without having some other abnormality like hypertension, abnormal blood sugars, cardiomyopathies, because using drugs for prolonged periods really breaks down every organ in your system eventually if you continue to use.
Thank you. And looks like somebody else just mentioned caffeine. I don't know if they're asking if caffeine
Withdrawal. I'm sure it's caffeine withdrawal. And I actually used to have that slide on here as well. Caffeine, and I actually was just talking about this morning, is probably the hardest overall to really come off of. And I actually spoke about this because I came off of caffeine probably 7 years ago now. I think it's 8 years. And I feel as though I woke up every day for 365 days and felt like I was never going to feel normal again. I wasn't going to be able to wake up and feel rested without having that coffee first thing in the morning. So caffeine is very difficult actually to come off of. You will see the same symptoms as like a stimulant withdrawal because caffeine tends to be a stimulant, but you'll see depression, hypersomnia, definitely increased appetite. There can be some anxiety, slowed mentation, slowed thoughts. I feel like I had a headache every day for 365 days, and I also felt never well rested. So caffeine is definitely stimulant withdrawal. And, I speak a lot about COVID. I do a lot of infectious control, and what I've talked about so much, everyone wants to hear about people abusing drugs and the worsening of abusing drugs over the pandemic during quarantine. And I always start that, yes, we'll talk about that, and that's very important, but we have to go all the way to the basics, that what people did during quarantine was a lot of self-medication. And it included not just drugs, but food and caffeine and tobacco. So people started to have self-medication to a point where they were becoming tolerant and increasing what they've been ingesting. And when they tried to go back to a little bit maybe more work schedule or going back into the office, they felt like they weren't accommodating so quickly. And a lot of it was withdrawal. So a lot of people, experience some depression and some anxiety. And of course, a lot of it has to do with COVID-19. but also a lot of it is the self-medicating behaviors that include not just drugs and alcohol, but the caffeine and food and tobacco and things like that. So there is withdrawal from almost everything.
Thank you, Melissa. And actually, we're going to stop now for our lunch break. I know there was another question, and since Melissa will be joining us at noon as well to discuss MAT, we can get to that question. I'll send that over to you, Melissa. So
Okay,
we'll
great.
break for a half an hour and rejoin around noon.
Okay.
And any other questions too, if people have other questions, you can feel free to send that to either the I would say send it to the channel that's called Blueprints Q&A. That's the easiest one for us to access. Thank you.
Thank you.
Do ASAM before the lunch break, but Lori King will be just tying that into her her training on residential care, which will be after Melissa's done as well.
What time do you need me to end, Dave?
I mean,
Optimally.
we have you down for 12 to 1, but if you go over that, it's fine. It's not a big deal at all. You know,
Okay.
we're
I want to
pretty
make sure there's
flexible here.
time for questions because
Yeah.
I know there's a lot of questions, and that's usually the most effective part, I think, for a lot of people. So I'm excited nursing students are on here, and hopefully I can teach them something new.
Sure. And it looks like, so what we'll do is, again, for those joining now, we have a username of Blueprints Q&A. So that's just a separate hookup. If you guys want to send questions there, then I can relay those to Melissa as well. So Melissa, do you want to do your Q&A after the fact, after you're done?
Yeah. I want to answer the one last question from the last session real quick, and it's not, a super great answer, but so the question was sources of cannabis withdrawal. Do the different sources change the withdrawal process? So unfortunately, when something is Scheduled 1 and it's not federally regulated, there tends to be not as many studies or studies that we can say have scientific significance. We know that there's over 500 components of marijuana and THC products, and we hear most common THC, CBD. Unfortunately, because there's no regulation, there's not a ton of literature. A lot of the studies are very independent studies. I think it's way too difficult to say how interchangeable or how similar or different each of the 500 potential components are. So I think that we really don't have enough research to say that like CBD oil or CBD versus a gummy versus THC and other forms, what all the differences are. I think that we have years to come before we're going to get really good information. So like I said, I am sorry that I can't give much more than that, but the typical withdrawal is what I went over. Cannabis withdrawal is typically mild, but it does definitely have symptoms. Dave, I'm trying to share my screen and it's saying that I'm not abled, the host disabled.
Okay. Let me check something on that.
Okay. If you need to share them, that's fine. I can, but I have it up and ready if I can open it.
I made you co-host, so you could probably try again and see if it works.
Perfect. Yep. There we go. Thank you. Okay, so we're going to talk now about medicated assisted treatment and harm reduction. Medicated assisted treatment has become one of my passions indirectly. I don't think 20 years ago I thought I would ever feel the way I do about it, or that really substance use disorder would have gone in the direction that it has in the past 20 years. When I first started in the industry, MAT or medication assisted treatment really only referred to methadone, and methadone was not originally marketed as quality recovery. So I call quality recovery an opportunity for someone not to just not use drugs, but to be part of society and be in relationships and be employable and actually have more than just not using. And I think methadone, when it first came out, was a way to control people financially and, forcing people that you have to come to me to get this. So I'm going to be able to control if you're using or not. And I don't know that therapy and quality programming went along with that. I think that it was originally that medication was the answer. We're going to make you come to me and put really restrict usage and parameters on you being able to get this. And that's how I'm going to make you sober. And substance use disorder is so much bigger than that. Opioid use disorder is so much bigger than that. So I think it's really important to focus on the fact that medication is really only one piece to the puzzle of quality recovery. On average, 23 million people in the United States over age 12 need treatment for substance use disorder. It's estimated that only 10% actually receive treatment, and those numbers are astounding. And this is when we actually are opening the conversation about substance use disorder. So they were actually worse than this prior to the 2000s plus. We have found in literature review and research that successful treatment has to include a combination of at least behavioral, and it's been beneficial, we have now found, with pharmacological interventions. So MAT must combine behavioral therapy with medications, I think, to have successful outcomes. As I was speaking about earlier, that with methadone, there was misconception that MAT only meant a substitution of one drug for another. What I think we have grown into, and with research and medical involvement of the medical community really getting involved in behavioral health, medications can be used to relieve withdrawal symptoms and psychological cravings that cause chemical imbalances in the body. And we'll talk about buprenorphine specifically and the differences that it may have from methadone and maybe why we're seeing more success. MAT programs are supposed to provide safe and controlled level of medication so that people can overcome abusing opiates and alcohol. And like I said, the research is now showing outcomes are reflecting higher mental capabilities, higher physical functioning, increased employability, and that is making a huge difference for people getting sober. So let's look at all the benefits of MAT. We know it increases patient survival rates. We know that overdose has decreased with the increased usage of medication-assisted treatment and all of the meds that are approved, FDA approved. There's increased retention in treatment programs, not only retention, but participation and engagement. There's decreased illicit opiate use and other criminal activity. Increased patients' ability to gain and maintain employment, which is probably one of the biggest experiential things I've seen in my MAT practice that I have. We've also seen a lot of improvement in birth outcomes with women with substance use disorder who are also pregnant. I'm lucky enough to work with an OBGYN who came into the field not with an addiction background. I was able to train her in most of her addiction background, but she came with the OB part, and we've been able to successfully treat a lot of pregnant women, which has been super rewarding because it's such a cautious population, and there's not a lot of experience out there. So I think we are coming a long way, and I hope to see a lot more studies in the future to make a big difference and show us what we can do and what we can do to keep people alive. So briefly, I just want to go over that MAT can work in one of two ways, and this is specifically looking at the FDA approved medications that you can use, and majority is for alcohol or opiates. So providers can give a patient opiates that activate the same receptors, but that are absorbed into the blood over a longer period of time. This will decrease or prevent withdrawal symptoms. And the goal is to break the psychological link between taking the drug and getting the immediate feeling of high or the reward system being activated. The second way we use MAT is that we can give an opioid antagonist. So it's a non-opioid drug that sits on the same receptor and blocks it completely. So if someone relapses, they should not get high. They shouldn't feel the stimulation of feeling high. And a person's tolerance for the drug decreases over a long period of time of sobriety. That's what the outcome studies have showed using antagonist therapy. So I will talk about what the different options are and what they do briefly, and then we'll have a lot of QA at the end. So there's multiple meds that can be used with cravings for drugs and alcohol. The ones that are FDA approved are buprenorphine, which you can see in multiple trade names that I listed, methadone, and then naltrexone. And I'm going to talk about all of these. I will talk about methadone, but I will say that I don't have a ton of experience. In my 20 years, I've never prescribed methadone. So I've used every alternative. Other than that, everywhere that I've worked, we have not used that. So I talk about what I know from research and not from experience completely. But let's look at alcohol use disorder specifically. The FDA approved treatments are Campril, Antabuse, and Revia. So I just want to look and see. Okay. So Campril is something that was used in Europe for quite a while. It was brought to the United States, and I used it a lot when it first came out. Some of the downfalls is that you have to take 2 pills 3 times a day with meals. So 6 pills a day is pretty difficult for compliance. It's not overly expensive. It's over $100, but patients often complain it's too expensive. And because people don't feel a instant effectiveness of it, they feel like it doesn't do that much. In Europe, it was much more accepted, and they have a lot better outcome studies, I think. One thing I definitely know from experience with Campril is when people took it, if they relapsed, they said they were not able to drink as much, and they got into treatment sooner. So that's still a definite benefit than nothing at all in the system. If you took Campril and put it together with behavioral modifications, there's definitely going to be a better outcome. But some of the problems with all of these choices that are in the oral version is that the patient still has the ability to choose not to take it. So that's some of the downfalls with some of these medications. Antabuse is pretty old school type of medication, and it is meant to make you violently sick if you mix alcohol with it. It is a difficult drug in the fact that you have to do a baseline liver functions test. You also have to recheck the liver functions in 4 weeks, and patients tend to be non-compliant and they don't want to go back for blood work. And once again, they don't feel like it makes a huge difference because it does not necessarily decrease cravings at all. It's a deterrent. So it's almost like a punitive treatment. And there are definitely people who probably had success with this, but in my 20 years, I've never had anybody be successful taking Antabuse. They figure out when to stop it when the next time they can have their next drink. So they would actually try to take it in such a way that they could drink on the weekends. And, being compliant with getting the blood work, definitely I've seen non-compliant. So I definitely don't write a lot of the Antabuse. Revia, which is the oral version of naltrexone, is it's okay in terms of people will take it to a point, but when they made it into the injectable version of Vivitrol, I saw a much better compliance and much better outcomes with it. Naltrexone comes in 2 doses. You take 1 pill a day and it decreases your cravings, and it's super effective for alcohol. And then for opiates, it completely blocks the opiate receptors. So we use it for opiates as well. And I'll talk about that even further. And it has a very high effectiveness. But for alcohol use disorder, this is pretty much our 3 oral versions, and couple this with a good therapy program and a patient working a program, you will see some success and outcomes of this combination. So let's go over to more specific opiates and talk about buprenorphine. That's probably the most commonly used MAT, I would say, today. If we look statistically, like in the VA system and the prison system, you're going to see a lot more methadone. But I think outside of those intra-facility settings, you're going to see a lot more buprenorphine. Buprenorphine is a Schedule III drug. It's a partial opiate agonist, so it does not completely saturate the opioid receptor like methadone does. And by being a partial opiate agonist, it can both activate and block the opioid receptors in your brain. Subutex is the version of buprenorphine that has no additive to it. That was what first came to market in 1996. And They found that there was some diversion with it. So they went back and did research again and created Suboxone, which is buprenorphine with naloxone. So naloxone is the same agent as Narcan. And some people get confused, like, how do you take that and how can you get the effectiveness of the buprenorphine without activating the naloxone? Naloxone is not activated if you sublingual absorb the Suboxone, which is the way that you're supposed to take it if it's the pill or the strip version. You're supposed to put it under the tongue and it's supposed to be completely dissolved. Now, if you were to chew it or try to inject it, that would actually potentially activate the naloxone. So that's how you can put that combination drug together and not have the adverse effects and have the positive effects, and to decrease any diversion that can happen. So buprenorphine, as I said, can be used under the tongue as Subutex. There is a newer version that's injectable called Sublocade. There is also a skin patch that's called Butrans that we do not use it for detoxing or for maintenance, but it is utilized for pain management. I've used it. I don't know that I found great outcomes with it. It was really expensive and people didn't see enough of an effect to pay the money for it, because even as like a level 3 medication, it was pretty expensive. There is also the implant version called Probufene, and I have also not used that. I've talked to the drug company quite a few times because they really want to get me started with it, and I'm open for it, but I know it's a long-acting implant. It usually goes under the skin and it can stay in place for 6 months, but I haven't gotten there yet. I've been spending a lot of my time on the injectable Sublocade, and we'll talk about that. Subutex, like I said, the buprenorphine sublingual, there are a lot of different names for Suboxone because there are some brand names out there. I already talked about the naloxone. And then Sublocade is a long-acting injection. And I'm pretty sure they have the slide with the details on that. So we'll talk further about that later, but that's usually given every 26 to 28 days. Butrans, we already talked about that. And the Probufene, we also already talked about that. Potential side effects of buprenorphine is sleepiness, drowsiness, decrease in respiratory rate, low blood pressure, potential for addiction, and headache. Let's talk a little bit about methadone. Pure opioid agonist. It means it acts in the same exact receptors in the brain, just like opioids, just like heroin, morphine, or codeine. The difference is it acts much more slower, and it has a longer half-life of about 8 to 59 hours. The thought is that methadone tricks the brain into thinking it's still getting the abused drug. The person's not getting high from it and is supposed to feel normal if they're in a good methadone clinic. And they're also not supposed to withdraw. The difference is that it's supposed to be being controlled, and that's the difference from being on the street and using unlimited amounts. Potential side effects are pretty much the same: respiratory depression. There could be some pretty bad cardiac abnormalities. Neonatal abstinence syndrome, which is when pregnant women take methadone, babies can come out with neonatal abstinence syndrome. And I do a 2.5-hour presentation on neonatal abstinence syndrome, but it is, babies addicted, born addicted to opioids. And anybody who's ever worked with newborns or labor and delivery, there is a distinctive cry from babies that have NAS, and it's really sad. But there's more studies coming out showing that buprenorphine has much less effect than methadone does. So that's really a positive outcome, but that is a potential side effect of methadone. Drowsiness, and then GI symptoms, nausea, vomiting, and then also headache. So naltrexone and Vivitrol. Naltrexone is anti-craving medication. Like I said, it's used for both opioids and alcohol use disorder. It can be a once daily pill with 2 different dosages. And then Vivitrol is an intramuscular injection that goes into your butt. The reason why is because it's 4 cc's. It's a very large IM injection. Generally, you only give 1 cc if you're going into the deltoids or the smaller muscles. So that's why it has to go into the butt, because it's 4 cc's all in one injection. It's an opiate antagonist. So any opiate product should not work But if someone already has an opiate in them and you give them Vivitrol, you can make the person go into precipitated withdrawal immediately, and they can become very, very sick. So before you give Vivitrol, you should always do your urine drug screen. Any medication-assisted treatment, you definitely should. You should also do a pregnancy test because it's not indicated in pregnant women. But there's a lot of really good success if someone couples this with a program. Because it's one thing to know that it's completely blocked and you can't have any effect if you use drugs, but you have to work on the behavior changes that go along with it. So Vivitrol, I have seen positive outcomes, but not the same as what I've seen since Sublocade came to market. And like I said, we'll talk about that a little bit later. But the goal is that these medications decrease your cravings for alcohol and also decrease your cravings for opiates. I don't think there's a lot of really good studies that show the effectiveness, but patients do report they definitely crave less. And then it blocks the complete absorption of any opiate if you were to take it. A lot of patients like to challenge the Vivitrol and they'd like to see if they can use drugs and feel it. And the earliest I've seen is that patients in day 22 to 26 feel that they have used drugs and they have felt the effectiveness of the drugs. Prior to that day 22, a lot of people do not report that they can feel anything. It's never good that our patients are challenging and seeing how far they can push it. But I've had a lot of patients over time that I think within that last week or so, there's definitely weaning out of the blockage. And if someone does use opiates, they can start to feel the effects of it. When I talk to patients about Vivitrol, I usually tell them, think of it as an insurance policy. You have insurance, it doesn't necessarily make you a better driver. I mean, maybe it makes you a little bit of a better driver. You don't want to spend more money, but God forbid you got in an accident, you have the protection of the insurance. With Vivitrol, a lot of my opiate patients would say they don't feel like it gives a whole lot of decrease in their cravings, or they don't really notice it's there that much. But I tell them, if God forbid they got themselves in a situation they couldn't say no, then they're not going to alter their brain chemistry by getting the high and getting the reward. So it will quickly get them back into a treatment program or wanting to become honest. Because that first time they touch that opioid and they get that receptor activated, it's really difficult to just will yourself to not use again. But having that Vivitrol and that blocker there, almost like as an insurance plan, it just gets you to get back on track. And I've gotten a lot of patients to get started on it based on that when they're in the inpatient setting and they're, not really sure if they're done using. I know that I've seen parents get a little bit of a relief for the first time, a little bit of an ability to be able to sleep at night, that they're not going to get a phone call that their child overdosed once they know that that Vivitrol is in their system. So it definitely has some positive effects to it. Some of its potential side effects include mostly GI issues, nausea, vomiting, some diarrhea, gas, or dry mouth, sometimes some anxiety and nervousness. There's also been some headache and dizziness, and I've used this drug pretty much since it's been on market, and I've seen all of those symptoms. Never to the point where people discontinue them, but they just kind of notice them. And oftentimes they're getting it like right after they're getting off the drugs and they feel like their system isn't kind of back to normal anyway. So it's usually pretty mild and not enough to make them want to stop. I had said earlier that if someone actually has opiates in their system and you were to give this to them, they would go into immediate precipitated withdrawal. The affinity for Vivitrol to the opiate receptor is higher than most opiates. So say they use drugs and say they use fentanyl and you didn't do a fentanyl screen. You just did a typical urine drug screen and you didn't know they had fentanyl. You gave them their Vivitrol. Vivitrol would actually knock the fentanyl off of their receptor. And that's why they would go into like immediate precipitated withdrawal. And what's really bad about that is almost no matter what medication you give them, they have to kind of ride it out. So it can be a minimum of 3 to 5 days of being really, really sick in opiate withdrawal and not being able to do a whole lot about it. So it's really important as you're using this drug that you're taking that into consideration. And for my nursing folk, a couple things to think about and little kind of pearls and tricks of the trade with Vivitrol. You have to take it out of the fridge at least 45 minutes before you're going to administer. It is a very viscous substance, and you have to mix the liquid with the powder. And if you can get it as warm as possible, it's the easiest to be able to administer and utilize. So even when I have it out for 40-45 minutes, I hold it in my hands and I roll it in my hand just so I can make sure that I'm getting it as warm as I can, because then you can administer it and it's not so bad. If it's really viscous and hard to administer, you're trying to get 4 cc's and you're going to be pushing on that syringe, and it only takes once, and then after that you become really savvy with it. But that's my little nursing pearl for giving Vivitrol. So Camprol, just to go over Camprol real quick, and actually its mechanism of action, it actually helps to restore normal function of the alcoholic brain. And I hate using the word normal, but it's, I guess, the best way to describe, but an improved functioning, I guess, from the alcoholic brain, I think sounds better, which has been changed over long-term alcohol abuse. And like I said already, it's 2 pills 3 times a day. It's pretty well tolerated. It has the typical symptoms of GI upset, fatigue, headache, dizziness, but none of my patients ever complained of the side effects. They only complained of the fact that they forgot, they never could get all 6 pills in a day, and then they felt like it was too expensive to pay for it when they didn't feel like there was a great effect of it. I was lucky in my career when Camprol actually came to the United States, I was able to have samples to actually give it to patients while in the detox setting. So that's where I was able to get my experience on how patients do with it. I haven't had, like I said, the greatest outcomes in the outpatient setting. Just they've decided to be non-compliant, and you know, they just don't feel like it's worth it to take it. So I don't use it nearly as much. Just some of the things I already talked about: anti-abuse. It's for problem drinking. It creates an unpleasant reaction to alcohol. It's in a pill form, 2 dosages, usually once a day. It's an alcohol antagonist. It interferes with alcohol's metabolism in the body. It also builds up a chemical, which is what makes you get so sick if you try to drink while you're taking the medication. So you shouldn't use any alcohol products. And I know that there's been patients in the past, even if they use a NyQuil or something that they don't think about having alcohol, it can make you very, very sick. And it's all pretty much GI complaints: severe nausea, vomiting, generally severe nausea and vomiting. A little bit of diarrhea will also come along with it. And like I said before, liver function studies must be checked before, 1 month after, and then periodically. And some side effects from longer term anti-abuse usage: drowsiness, tiredness, headache, and then also acne. Now, Sublocade. Sublocade is something that when I actually started doing this presentation, it was over 2 years ago, and Sublocade was just coming to market. So I was very new in my experiences. Sublocade was approved in December of 2017, and it actually got onto the formularies for insurances in the United States by about July of 2018. So my very first patient was actually June of 2018 who paid cash, who was on it, and still to this day is getting Sublocade once a month and is still sober, which is pretty exciting. So Sublocade is an injectable buprenorphine, so it's a long-acting buprenorphine. It doesn't have any other additives to it, no naloxone in it. It's a 28-day injection. You can go as early as 26, but it's not recommended to go any earlier. It can only be handled and administered by medical staff. Sorry, there's a spelling error in there. The risk of diversion is essentially removed by making just medical staff be able to inject it. It generally comes, it says in here, clear, viscous, colorless to yellow to amber. I've always seen it in a yellowish to amber presentation, and I've always seen it clear. I've never seen it viscous, but they want it to be clear that it can be in all of those presentations. And it's a sterile solution. It's already pre-mixed in a needle, ready to go. They send their own needles with it, so it's its own little package. It comes in 300 and 100 milligrams, and it's in a 19 gauge 5/8 inch needles, what they utilize it. let me see. I want to see what I have down here. Oh, good. I won't go ahead because the next slides go through some of the stuff I was just going to go over. We already went over what buprenorphine is. One thing that's important when you're prescribing Sublocade is that someone needs to take buprenorphine at least 8 milligrams a day for 7 days before they can get their injection. And the way the injection has been approved by the FDA is in month 1, you take 300 milligrams. So you do 7 days of buprenorphine, 8 milligrams. Now you could be on more than 7 days. It's a minimum of 7 days. So you have to take buprenorphine by mouth every single day. On day 8, I usually give the 300 milligrams. It goes subcutaneous into the abdomen. The abdomen is the only location that you can administer it. You give 300 milligrams in month 1, 300 in month 2. Month 3, you try 100 milligrams. If there are any complaints at all, you go back to 300 and that becomes their maintenance dose. If they do well on the 100, you can keep them on the 100. What I have found since I started utilizing it is that I go 300, 300. There's a good half of the population that does real well with the 100. They go on the 100 and they do great. One of the symptoms, which I didn't realize at first was a symptom to look for, that even cravings on the 100 is enough to indicate that you go back to the 300 milligrams. So cravings are usually the biggest thing that I find that people complain of while they're taking the 100 that makes them go back to the 300. The other thing I also have seen is that I had a couple patients who were on the 100 for a couple of months, and they came in and they were complaining about what they were describing as psychiatric complaints, that maybe their psychiatric meds weren't working as well as they usually do. They were complaining of their sleep was becoming restless. They were getting more irritable. And after I did a really good inventory, what I realized was a lot of their symptomatology was more addiction symptoms that looked like it could have been psychiatric med management needed, but really when I upped their Sublocade back to the 300, they virtually all resolved. What I have found most using Sublocade is that, the first 18 years of my career, we know addiction is a brain disease, as all the psychiatric diagnoses are. What we often did was treat addiction with psychiatric meds that we typically use for depression, anxiety, bipolar. And we started psychiatric meds much earlier. So if we go back 20 years, we didn't give any psychiatric meds. We wanted to get people completely clear to really see the picture of what we were treating. And then we realized that people had so many psychiatric diagnoses, probably in most of my settings, at least 80% of my substance use disorder population, that we weren't getting the psychiatric meds started in time or diagnosis properly given, because we were focusing on really trying to clear up the brain. And the brain doesn't really work like that. The chemicals are continuous every single day. And we were putting people at risk for relapse and going back to their drug of choice or abusing some other drug. What I have found is by adjusting the Sublocade, I've actually been able to decrease a lot of psychiatric meds in my patients because most of their presentation was really the addiction and not as much as I had thought in the past of a psychiatric presentation. So my hope with an injectable like Sublocade, and I am going to talk a little bit about some of the other injectables that are coming to market, I think it's going to allow us in the substance use disorder treatment side to truly treat the brain pathways associated with addiction and maybe decrease some of the over-diagnosing of other psychiatric diagnoses of depression, anxiety, bipolar specifically. Because we now have drugs that specifically treat addiction. And then as we satisfy the addiction pathways, we can really tease out if any of the other psychiatric diagnoses are present. So some more specifics about Sublocade. It must be kept in a refrigerator. This one you remove 15 minutes before administration. I said earlier, Vivitrol is 45 minutes. Sublocade only takes about 15 minutes. It can remain at room temperature and be used for up to 7 days, which Vivitrol is also the same thing. So if you pulled a Vivitrol out for a patient, and say they don't show up or they don't come or whatever, you actually have 7 days to use that. Vivitrol, I have seen by experience, you can tell when it becomes inactive. It becomes very clumpy as soon as you mix it together, and that's how you know that it's not good and you can't utilize it. And so 7 days is kind of like the max, but you cannot refrigerate either one of those drugs. Once you pull them out and let them be out and start to get to room temperature, they're not effective if you try to put them back in the fridge. As I said earlier, it's given into the abdomen, and it's the subcutaneous tissue of the abdomen. If someone were to attempt to use Sublocade IV, it could actually end in death. When I inject it, it actually creates these little depots. And I actually think it's like if you took like 3 Tylenol capsules and put them next to each other, that's what it feels like under the skin. But a lot of my younger population says it feels like a Jolly Rancher. So when I ask them how they're doing, they'll say my Jolly Rancher's smaller, or I can still feel it. But the company refers to them as little depots. They go under the skin. From one injection to the next, you rotate your sites, but you can actually see where the residual one is. So one thing that has been really good for my population is that when they can feel that, they know it's releasing. So part of the addictive brain is the habitual taking of something. And if you're not taking something, then you're going to get sick. There's always that impending going to get sick. So when you first are transitioning someone onto a long-term injectable like Sublocade, I realized that patients are working a lot on their behaviors and changing their behaviors and realizing I'm not really sick. It's in there, it's releasing continuously. Like I don't have to worry about it. Now I can focus on actually doing my treatment and my therapy and work on my step work and work on quality recovery. There is the capability that if there was an emergency situation for some reason, the depots had to be removed, they could be taken out surgically within 14 days of the injection. I don't know anybody who's ever done that. I don't know how to do it myself. There was supposed to be a class on it, and I have not seen it ever really come out. But that is something that could happen if it were needed to. Some adverse effects from Sublocade could be like you would expect, but risk of respiratory and central nervous system depression, same as buprenorphine, if you use it along with benzodiazepines and CNS depressants like alcohol. So you definitely don't want to combine the two. It is not contraindicated though. It's not contraindicated. It's not ideal to have the two together. There's a risk of serotonin syndrome. You should use caution when operating hazardous machinery or driving. Dependence can happen and withdrawal may happen. Now, when I first used to give this presentation, it's when the drug first came out, so I really couldn't give any experiential information on this. But what I've seen over time, I've had minimal people relapse. I think I know of like 4 people who actually relapsed with opioids while getting Sublocade. And what I've seen in those experiences, most of them have gone to the inpatient setting, and none of them have required taking any buprenorphine to withdraw. So the patient received their Sublocade. Within 3 weeks of receiving it, they relapsed. All these people relapsed with IV. They thought they were doing heroin. Most of it was fentanyl. So they had positive urine tests for fentanyl and for buprenorphine. They complained mostly of fatigue and diarrhea. And during the withdrawal process, it wasn't really withdrawal. They really complained of minimum symptoms. They didn't feel great, but a lot of it was regret, remorse for having used, and not actual physiological withdrawal. And most of them just went right back onto their next injection. They just went to their next scheduled injection. One of them actually took the buprenorphine by mouth for 7 days again because they went beyond the month. But they did not do like a buprenorphine taper. They didn't have to detox. They essentially took the dosings and got their next injection and went on their way. Things that we found that are really positive is, all the people that use, the one kid really wanted to challenge the Sublocade. He wanted to see how much he could use, and he used probably 2 bundles of fentanyl, and he didn't overdose, which was, unbelievable that he did not. But we know that buprenorphine has decreased the overdose rates. I don't know that we have enough literature to explain completely why, but there's definitely been a reduction in overdoses. And I now have 3 patients who decided to stop Sublocade because 2 of them got past 18 months. 24 months. One of them just right now, she's on 3 months. Since their last injection, they just didn't get their next injection. I've still seen them every month to kind of record what their symptoms look like, how they feel, if they're craving, you know, where they're at. And all 3 of them, 2 of them are not in programs. They still do their, because they, you know, they're done PHP, they're done IOP, they're even through their GOP. 2 of them, they have a therapist that they'll see every 3 months, just maintenance, but they're not, they do their meetings, but they're not in an intensive program right now. So they just got their last injection, and the biggest complaint has been fatigue. They don't feel like their cravings have increased. They're in good support systems. They've been able to keep their jobs and do all the things that they normally do. One of them is still pretty heavy in their GOP and their intensive treatment. They do a lot of individuals, and that's their choice. It's part of their journey, but none of them have gone back inpatient. None of them have relapsed. And that's only 3, because in 2 years, nobody has really decided to come off. They've stayed on it, and they feel like it's pretty much been a game changer for them. One of the last things I wrote on here is that Sublocade can be positive in your UDS for up to 1 year after 1 injection. I have found at 3 months, I found it negative. So these couple people who have come off, they've been off for 3 months. They were positive month 1, month 2. At month 3, their urine was negative for buprenorphine, but the company issues that it could stay positive for up to 1 year. And it doesn't say what the quantity would look like. And, you know, there's unknowns because this is a new drug. It's a new drug that was brought to market in an infancy state. And infancy is not easy to get approved by the FDA, but what that allowed the company to do is to be the only drug on the market for 3 years. Usually that's not how long you can go, maybe a year, 18 months, but to get a full 3 years before any other drug is allowed to come to the market is kind of unheard of. But that leads me to the last one I want to discuss, which is called Brixadi, which I did not love this name at first, but the only way I can remember it is I think Break Addict. And that's how I get Brixadi. But Braeburn is a pharmaceutical company that has Brixadi, and they've had it ready to launch since the time Sublocade came to market. Sublocade got there a little bit sooner, but what that created for Brixadi is the ability to take an extra 3 years to almost perfect what Sublocade came out with. So Brixadi is going to be FDA approved for extended release injection for the treatment of moderate to severe opioid use disorder. The difference is they're coming out with versions that can be weekly and monthly. They're coming out with multiple doses in both of those compositions. So there's an 8, 16, 24, and 32 for the weekly. Monthly is 64, 96, and 128. The other positive thing with Brixadi is that you only need 1 day of transmucosal buprenorphine before you can get the injection, whereas Sublocade, you must have 7 days of it. So that's also a big difference. Like I said, they're not eligible to do marketing in the United States because of the exclusivity that Sublocade got, but we're now on the tail end of it. So I'm 2 years into using it, 2 years into Sublocade being in the United States. Come 2021, Brixadi is going to come to market, and I think it's going to be another game changer for substance use disorder, for opioid use disorder. I'd like to end on pretty much like my last patient who I have is like my poster Sublocade patient. He came to me in July of 2018. He at the time was 32 years old. He had been using opiates since he was 18 years old. He did some oral opiates 16 to 18, but turned to heroin at 18 years old. He's like 6'5", 300 pounds. He came into my office and his face was super red, and he just screamed and cursed at me the whole time that they forced him to get this injection and he won't let me give him another one. And he's going back on the pills and there's nothing I'm going to do about it. And I shook my head and I'm like, okay, you know, because I have to remember, and in this industry, you have to remember they're sick, I'm well, I'm not going to take it personally. He came into me on 7 psychotropic medications. He was on Lexapro 30, Seroquel 300 at bedtime with some PRN during the day. He was on Requip to fix the restless leg syndrome because he was on so much Seroquel. He was on Visceral PRN. He was on Remeron for sleep, in addition to the Seroquel 300. And then he was on Lamictal 100 twice a day. He was diagnosed bipolar disorder. He had no sobriety, not more than 30 days from 18 to 32 years old. He has not held down a job in his lifetime, has not been in a relationship because he's been using drugs since 16. So this 32-year-old 6'5" man is really a 16-year-old boy in front of me who's angry at the world because someone stuck this needle in his stomach. And I was going to see him every week to see how he was doing because he was a brand new injection in the inpatient setting. And I was seeing him in outpatient. We wanted to see, how he's going to do. He's one of our very first Sublocade patients. So we got towards the end of the month. I saw him every week. He cursed at me every single week and he was compliant with his meds. It came time to order his second injection and I verified with him, you're going to take the injection or are you really going to push to get back onto the pill form? He's like, I'll do it. I don't want to, but I'll do it. So I ordered his second injection. I gave it to him, saw him every 2 weeks from there. Got to his third injection and he kind of got more angry again. He was on that 100 milligrams and he was craving all month. He wasn't doing well. I gave him some supplemental buprenorphine by mouth to take until his next injection was due. Got him back up to the 300. After about 6 months of that 300, so we're talking about a 9-month total sobriety for this gentleman. His face wasn't red anymore. He stopped cursing at me. He came in much more timid and much more talkative than he had ever been before. And by 12 months, he had asked, can we look at some of my meds? Because I feel like overly tired. I'm having symptoms of headaches. And it didn't seem as though it was coming from Sublocade because he was pretty well maintained on that. And so we started backing off his meds. And all of a sudden I started peeling the onion to the typical behavioral health patient and getting down to the patient who was being satisfied on his addictive disease processes. And then we were finding the true psychiatric diagnoses for this patient. He also was on a blood pressure medicine. He came in hypertensive. And as we went through time and he was no longer withdrawing all the time or running after and abusing heroin, his blood pressure normalized. He did really well. So now today, he is 27 months sober. I see him in 2 weeks. He's been on Sublocade every month. He's been compliant every single month. He's never needed any supplement of PO. He's never had a positive urine for anything other than his buprenorphine. And as of today, he's on Lexapro 10 and he takes Seroquel 12.5 as needed for sleep. He doesn't present with any bipolar presentation. I do a mood disorder every time I see him. I do a PHQ-9 every time I see him. He lives in his own house. He speaks with his parents. He is a foreman or a manager at his job that he's been at consecutively without call outs and latenesses and, hot drug screens. And he feels like for the first time in his life, he has quality living. He has quality recovery. And he is my poster child of what I think a long-term injectable has done for opioid use disorder in this population. So I just want to end with that. Questions, I guess.
Thank you, Melissa. There were some questions that came through. I'll relay those and then we can open it up as well.
Okay.
There was one question, I'll read it. It's as a PACURN. I've gotten answers from anesthesia regarding methadone administration and how long they need to wait before getting opioids prior to surgery and post-op. Shouldn't the methadone or Suboxone cancel out the opioids effects? And why do patients still take the methadone the day of surgery?
So, okay, there's a lot to that question, and I definitely am not in the PACU or the OR world, but ironically, I am working with a pretty large orthopedic group who wants to try to figure out how we can start using these alternatives, the partial opiate agonists, buprenorphine, for pain management for patients. So unfortunately, this is a very uncharted territory and research is very limited on safety methods of using buprenorphine and all of the drugs that we have out there. So methadone is a very long half-life. Before I'm to give someone buprenorphine from methadone, we wait at least 48 to 72 hours. But it more has to do with how long they've been on it and how much they're on how much we alter it and how we utilize it. They can take it the day of surgery because it gives them the pain protection. So the methadone you have to think about is equivalent really to them taking a Percocet. So that's not really any different. If they're taking the buprenorphine and it doesn't have any naloxone or anything in it, that also is just giving some potential pain coverage to the receptor, and it doesn't have any negating medication in it. So they're safe to give day of. I have 2 patients who I actually managed with buprenorphine post total knee replacements, and they never took any opiates for pain management. I talked to the anesthesiologist. I don't know exactly what they altered and what they did, but they knew it was buprenorphine that was on board. And when they came out and they were in the PACU, I resumed their buprenorphine dosing that they were at, which this gentleman happened to be at 16 milligrams. I had to go up to 24 for pain management post-surgery, but all I did was break up the dosing, where normally I only give once a day dosing, but if I'm going for pain management, I break up the dosing. And this gentleman got through a total knee replacement and a revision, never having taken any other opiate, being managed on his buprenorphine maintenance with no problems. I don't know if that answered every part of the question, but that is a very intense question that we definitely do not have enough research on. And we need to get providers who will just start trials. We need to do trials and research to really find out how to fine tune how much, because if you look in a normal FDA approval, Percocet 2 pills every 6 hours is a normal dosing. Well, for a heroin addict who does 2 bundles a day, you're not even touching half if you're doing 2 Percocet every 6 hours. That's why when they come to the hospital, the nurses can give them that. And they're like, this patient's complaining of extreme pain. And they have someone bring in extra stuff for them because their tolerance is so high. It's not an FDA regulated amount, which is the problem when you mix methadone and buprenorphine with any surgery procedure. I hope that answered partial at least.
Thank you, Melissa. Yeah, and I do want to invite Dr. Kelly Coons, and I believe the nursing students here are either MSN students preparing to be family practice
Awesome.
Nurse practitioners, or are already nurse practitioners. So I know that that's who joined the call here at 12 o'clock. So we're going to open the floor. If you guys have any questions, if anyone wants to type them in, if you want to just jump on your video and turn on the microphone, I'll turn my microphone off.
I just wanted to say thank you for including the very important information for the nurses. So I have quite a few future NPs on the phone or on the call, as well as 2 DNP students, one of whom is doing her project and trying to improve provider ordering of MAT in the ER. Yeah. And another one who is a psych NP and is just starting in her role as a psych liaison at UPMC. So I think,
awesome.
I think Kelly just posted a question in the chat, which was, are there specific requirements for her as a psych NP to be able to prescribe the injectable buprenorphine?
Yes, so you have to get the data waiver 2000, which you have to do so many credits so you can be approved, and then you have to apply, and then you also have to apply for a special DEA, which will give you an ex-DEA number. There's a lot of caveats to Sublocade that you can only administer it at the location where it was delivered. So I work in multiple locations. For me to give my Sublocade in all of my locations, I would actually have to have my DEA license at every single location that I work at. So I've been waiting for the company to improve this process because that's pretty laborious. And, I have 2 of my locations, but I have multiple other sites I go to. And what we've done to get around it is providers who are just at that site, they have the Sublocades ordered under their name. And then anyone within the site could administer it, because anybody with a DEA license or who's approved can give it, but you can only give it at the location where it's delivered. some other things that I'll just add in because you're the people who I need to talk to because I can't get enough people out here to help me. I actually give a numbing agent prior to giving the Sublocade. I do a 1.5 cc mix. I do 1.5 cc's of lidocaine and 1.5 cc's of bupivacaine. I administer that first. I wait 10 minutes. I do my questions and my catch up and follow up with them. Then I administer it because if you don't do any numbing, there is a report that it's an extreme burning. It goes away and some patients think it's tolerable. Some definitely think it's not tolerable. Some providers I've seen give ice. Put ice on the skin for 10 minutes prior to giving the injection. I've had a couple patients who are willing to try that and they were like, oh no, Melissa, please do the numbing agent. And the numbing combination, it really has been, because who wants to come to get something in the first place that is super painful? They don't want to do that. So I have a great compliance because I do use that numbing agent prior to.
Thank you. Are there any other questions for Melissa?
Dave, you can share my email with anybody on the line, especially nurse practitioner students, new people coming out into the industry. I mean, I went to school and graduated in '99 and I love having students. I don't think that there are enough providers out here working with MAT, working with behavioral health, and doing it in the year 2020 and doing things different from what it was before. And we're on the forefront. We are doing the research. We're creating what's out there and what the options and opportunities are. So I love to talk to anybody interested in this field because, like I said, there's not enough of us.
Do you know James Nagundu in York?
I don't.
He actually he's a family nurse practitioner who is his clinic is mainly MAT.
Yeah.
And he helps us a lot as well. I will send your email to him as well because I think the two of you would be good collaborators.
Great, that's great. I appreciate it. And if anyone has questions, they can email me the questions and I'll get back to everybody as I can.
Yeah, absolutely. And definitely, what's not seen right here, there's some people behind me, but our team is still in here. And I mean, we all understand MAT to an extent, but just hearing you give your training on it, I mean, that helps all of us in the field too. This being OLEP, opioid workforce expansion program. So we are part of that opioid workforce and just hearing your perspective on it and just how much more in depth it is. I mean, that helps me being on the outreach side of things and to be able to work with, getting a better understanding of that to help with level of care. I mean, it's wonderful to see. So thank you so much. For those who don't know, Melissa really was kind of a last minute add to this, and she was very willing to step in, and just seeing that the passion goes a very long way. So we do appreciate that. And again, if anybody has other questions, if something might come up down the road with some of the other presenters, if there's something you think of like, oh, I wanted to ask Melissa that, what we'll do is we'll work to, I guess I could work with Danielle, and I know they send out the group-wide email. We can get all the email addresses on there. So if people do come up with any questions or along the way with your studies, if there's other questions you may have, we would like to help out as best that we can.
Yeah, absolutely. Absolutely.
All right. And what we're going to do is we're going to go move on in a few minutes here. Lori King is going to be discussing ASAM and residential care. So we're going to take a brief break just to get her set up. So Melissa, again, thank you so much for joining us.
No problem.
And, we'll be back on, let's just say in about 5 minutes. We'll just take a quick break just to get everything switched over to our end.
Okay. Thank you, guys.
Thank you.
See ya.
Okay. Does everyone hear us okay? Everyone hanging in there? You don't need to say anything. I don't want to create a bunch of feedback, but I appreciate everybody that's participating. So we're kind of calling this like the meat and potatoes of our training. You know, we started out early talking about the admissions process, outreach, billing, and all the other things that more of the behind the scenes kind of things that you don't necessarily think about when it comes to treatment and the continuum of care. So Melissa did a great job talking about MAT, which is used at all levels of care, really. What we're going to do next is Lori King is going to be presenting about talking about ASAM, which is part of the continuum of care, and she can explain that way better than me, so I'm not even going to attempt that. And then she'll segue into residential care. And then after that, Alexis Milner, who actually I unfortunately do not have a picture of her on the screen, but you will see her shortly. She will be discussing PHP, which is Blueprints. We have a partial hospitalization program, so that's she can definitely hit on that a lot. Might throw another little break in there somewhere, and then we'll be joined by Deb Smith and Clarice Tinson as well, who will also discuss more of the outpatient services. And I'll wrap things up and discuss some aftercare, talk about 12-step meetings and alternatives to 12-step. So without further ado, I'm going to give you Lori King.
Good afternoon. So the ASAM is the American Society of Addiction Medicine, and they developed a nationally accepted standard of clinical guidelines, which we utilize, and all the programs, the drug and alcohol programs here in Pennsylvania utilize to determine an individual's medical necessity for level of care placement, continuing care, and then transfer and/or discharge recommendations. When we make treatment recommendations, we use self-reported information that's gathered during an individual's intake to determine the appropriate level of care. The ASAM indicates that appropriate placement should be identified as the highest level of care to accommodate an individual's needs that would not be able to be addressed at a lower level of care. So you'll see that the ASAM levels of care range from 4.0 with the highest level of intensity at level 4 to early intervention at level 0.5. The levels of care are designed to be fluid, meaning that throughout a client's continuum of treatment, we would be reassessing them during the course of care. And this would allow either for a referral up to higher level of care if necessary, or a step down through the continuum of care while moving toward completion. In a perfect world, you might have somebody starting at the highest level of care and they would very seamlessly step down as appropriate throughout the course of treatment to completion. However, that's not always the case, and most oftentimes there will be a relapse at some point. Therefore, we need to reassess them and again, make a referral that's appropriate to meet their needs at that moment. We will be discussing each level of care a little more thoroughly in later portions of the presentation. However, just as a broad overview, so your level 4.0 is going to reflect an intensive drug and alcohol program within an acute care setting. So that would be like a hospital. And that's basically to accommodate needs that require primary medical and nursing care. Level 3 would encompass residential treatment facilities, and they will vary in medical and clinical services based on individual need. Level 2 is comprised of higher intensity outpatient services, which is really what we provide, 2.5 and 2.1. And we also provide level 1, which is general outpatient services. So you'll see that point 5 is listed. It's early intervention. So it's not at an actual treatment level of care, rather just providing psychoeducation and assessment. Admission to the highest intensities of care will involve rigorous assessment on dimensions 1, 2, and 3 of the ASIGN criteria to assess an individual's ability to participate in treatment activities based on any presenting withdrawal, biomedical conditions, or severe mental illness. So the slide that you'll see now is the 6 dimensions that we utilize to assess an individual and then make a level of care determination. So we're tasked with developing and utilizing assessment tools that assist in assessing the individual across these 6 levels of care, or I'm sorry, these 6 dimensions. So dimension 1 is acute intoxication and or withdrawal potential. The higher the rating on this dimension, the more intensive services they would receive. So I had another slide. We kind of switched up the order of everything. Detox, which is referred to as withdrawal management, utilizing ASAM language, is offered at 4.0, 3.7, 3.5, and then ambulatory detox is also offered at outpatient levels of care. We don't offer that service here, so I won't speak about that at all. And Melissa obviously presented her information on detox. So based on dimension 1, if there's any intoxication or withdrawal potential, a client would absolutely be recommended to engage in a program that has withdrawal management available. On dimension 2, we're assessing any biomedical conditions or complications. So for instance, many of our population, the clients we see may have diabetes or different pain management conditions. There could be a host of high blood pressure. There could be a host of biomedical conditions. So depending on the severity and how well they've been managed and or neglected, we would also need to factor in the level of care that would be appropriate to address those issues. On dimension 3, you'll see that this would encompass emotional, behavioral, or cognitive conditions and complications. This would include severe mental health issues. Therefore, so some programs are strictly drug and alcohol, and there are some co-occurring capable or co-occurring enhanced programs. We need to assess this very thoroughly and rigorously to determine what an individual will need in terms of mental health management. If there are any presenting suicidal ideation or recent suicidal attempts, homicidal ideation, we would really want to make sure that they're being referred to an inpatient program that can accommodate the severity of their mental health, and they would need to be stabilized before engaging like in a lower level of care such as outpatient. Or the readiness to change on dimension 4 is really to gauge, so I don't have a slide for this, but we use an assessment. Deb will probably talk about it in her portion of the presentation, but we utilize a Eureka assessment, and that's to assess a client's stage of change. And so we're just trying to gauge, again, if they're in a place where they're ready to make some changes, they might go into a lower level of care versus someone who's a little more resistant, maybe facing some external motivation, like legal obligations to engage in treatment, and they may need to go into a higher level of care. On dimension 5, we're assessing for relapse, continued use, or continued problem potential. So if someone's presenting to treatment for their very first time, and again, has a supportive environment, and again, based on, lower risk ratings and some of the other dimensions, they might be recommended to engage maybe in an outpatient level of care versus someone who has a history of continued use despite consequences, a history of multiple relapses, multiple treatment stays, they might be recommended to a higher level of care. And then dimension 6 is looking at the recovery or living environment. So many of the clients that we see at the outpatient level, they may be residing in recovery residences, which provide structured housing that's supportive and sober, versus maybe living, some people are homeless. We need to work on housing with them. For a client maybe that has a domestic abuse situation at home, though they would obviously have a higher risk rating on this dimension, and we would work with them to get them into provide any residential care here. We at least wanted to touch on the different levels of care. So, and I'll also talk about the difference. You'll see ASAM level 3.7 is medically monitored intensive inpatient services. 3.5 is clinically managed high intensity residential services. And then 3.1 is clinically managed low intensity residential services. So for level 3.7, you may just hear this referred to as inpatient or rehab. Again, this might include withdrawal management or detox. A physician must be available to assess the individual within 24 hours of admission, and then provide any ongoing continuing care throughout the client's presentation in inpatient. The nurses are staffed 24/7. At this level of care, the client may receive psychiatric, lab, toxicology, just a wealth of care coordination happens at this level of care. And this is mainly to basically stabilize them both medically and with any sort of presenting mental health symptoms. The programming is pretty intense, and that will include daily clinical services, medical and nursing services, counseling and clinical activities, and the medication at this level of care is administered by medical staff. At level 3.5, so this is, again, typically your rehab. There would be no detox at this level. The facilities would need to be able to provide access to a physician assistant, or a nurse practitioner as necessary 24/7. Again, the medication at this level of care is administered by medical staff. So because before we transitioned to ASAM, and that was just about 2 years ago, we were using an old placement criteria here in Pennsylvania. And there used to be dedicated lengths of stays assigned to each level of care. The ASAM has really allowed us to be able to individualize treatment. So a client that presents to inpatient historically used to be about 28 to 30 days. In some cases, they may only be receiving services for 7 or 14 days. So care coordination and aftercare planning really start the day that the client presents to the inpatient facility, so that they can be appropriately referred down for a step down. They would still receive intensive clinical programming, so a lot of group work. They would have a primary counselor that they see for individual sessions. Family sessions are offered at this level of care, and then other clinical activities. The focus is on relapse prevention, and fostering pro-social behaviors and community living skills. Again, the length of stay is going to vary on the client need and meeting medical necessity according to the ASAM criteria, which again, clinicians should be utilizing to assess readiness for a step down. There are multiple different forms of recovery support, which are offered at this level of care. And they can talk a little bit more about that, but still accepted 12-step recovery, smart recovery. There are different things, spirituality. Some facilities will employ holistic supports such as yoga, meditation groups. There's, recreational therapists at different facilities. So that would all be inclusive at this level of care. And then the last level of care in the residential continuum is the clinically managed low-intensity residential services. So this is traditionally referred to as a halfway house. I did want to state, so there has been some confusion over time about the differences between a halfway house and a recovery house. So when people are referring to a halfway house in terms of treatment, they are referring to this ASAM level 3.1. They are still, so they will still have a primary counselor. The goal here at this level of care is to help clients reintegrate into the community. So they will still receive their clinical programming. However, the frequency is less than in an intensive residential program. And the focus here is really on skill building, daily living skills, and getting out into the community either through employment or volunteer work. The big difference here in terms of medication management is the staff will monitor client self-administration. So the facilities are still responsible for medication storage and maintaining records of all the different medications that the clients receive. However, we monitor at this level of care. Oh, I'm sorry. Are there any questions about any of these slides, the ASAM or the residential treatment?
All right, good afternoon, everybody. My name is Alexis Milner. I'm the clinical supervisor at our partial hospitalization program, also known as the Chapter 1 program. I'm going to go through and kind of explain to you what we offer, the different things that we do in terms of clinical services, as well as the independence for people that are transitioning. So first, just to address, PHP is a partial hospitalization program. The way we operate is a minimum of 28 days of treatment for substance abuse. However, depending on your need to stay longer, we do work directly with the insurance companies. As long as they support the clinical assessment, we can always look at extensions. So the way that the levels of care would work, you would have detox, inpatient, halfway houses, partial hospitalizations, IOP, and then OP. So just to kind of touch base on what Lori had just shared, we are considered ASAM level 2.5. So some other things that we offer, which makes our program a little bit more unique, is we're one of the only partial hospitalization programs in the state of Pennsylvania that do offer transitional living. And with that being said, that makes a major difference with the people that we're bringing in. So we do offer aftercare planning. We help transition to other services, any outpatient providers, from medical to mental health. And we also help transition them into sober living and recovery houses. So looking at the Chapter 1 core program, we offer groups daily. Individual therapy is also offered. They will meet with a primary therapist twice per week to address any needs and concerns. We do offer medication management services, including MAT. So we do work directly with Melissa. She's the one that does all the prescribing for Suboxone, Sublocade, Vivitrol. So we work very closely with her. We do have a psychiatrist on staff who is Dr. Asim Rana. He provides psychiatric evaluations and follow-ups in order to help people who are struggling with mental health diagnosis stabilize on medications that are appropriate. With that being said, we also participate in community recovery fellowships and support groups. We are really involved with 12-step programs that are offered in Lancaster, from refuge recovery to smart recovery to NAAA meetings. Prior to COVID hitting, the clients were able to attend outside meetings daily on a weekly basis, but with COVID, we are encouraging them to engage in Zoom meetings. We offer a lot of case management services. Like I said, the purpose of this is to help individuals integrate successfully back into the community. So we help individuals get food stamps completed. any medical assistance that may be needed for those that come in on county funding who do not have access to reliable insurance. We help individuals do research regarding furthering their education, whether that would be wanting to look into taking college courses or needing to obtain a GED. We help them job search. It's really important that they do have this stuff lined up for financial stability in the recovery houses. Due to needing to pay rent weekly, they are responsible for their own toiletries, their own food. So that's really important. Like I had said, we also are really focused on helping set up any medical appointments, especially PCPs, any mental health providers, and that includes individual therapy. So we work closely with a lot of different providers in Lancaster City. For Chapter 1 benefits and amenities, sorry if I said that wrong. So one thing I really love about this program is we encourage all clientele who comes in to remain independent. So to kind of get them in the swing of things, because the different people that we do take in, certain people struggle with different things. Depending on how they were living and living in active addiction, they look very differently versus people that are sober. So what we do is we provide them $60 a week for groceries. We do take them to the local grocery stores so we can kind of encourage them to learn how to be responsible, learn how to budget, and with that, like learning how to cook. So this is that actual picture of one of our kitchens that we offer in the residential houses, which also is a huge pro from what I hear regarding feedback. We supply household supplies. We have a washer and dryer unit. We have all of that. That way they can learn how to be responsible like adults. We have 2 male houses, one in Columbia and the other one in Hallam, and we have a woman's house in Columbia. The way it's set up, it's kind of like your traditional private suites in colleges. I'm not sure how Millersville is set up, but that reminds me how the setup is. Most of them do have private bathrooms, so that's also another plus. And we also provide access to supportive social, economic, and employment resources. And another one that's really important is we do allow individuals to have their cell phones after a 7-day blackout. The use of the cell phones have become in handy for those that need to stay in contact with sober supports, family, sponsors. If anybody comes in that has a lot of medical appointments going on, if there's any legal stuff occurring. So we definitely encourage that. So the way that the program looks, we work with the majority of different people. First, I just want to say that everybody in this room that's presenting, we work all together with getting this Chapter 1 program, keeping it functioning and keeping clients coming in. So one that we have the primary therapist. Right now we have 5 of them. So as clients come in after the admission process, they are assigned a primary therapist. And then we have clinical specialists who are, some of them are counselors, assistants, and what they do is they run afternoon groups, they help put out fires as needed, they meet with clients as needed. So it's just additional clinical support. We have logistics coordinators. So one awesome thing too about this program is that we offer transportation to outside appointments. We offer transportation to recovery houses that do require door-to-door transfers. Residential coordinator. So we also have an aftercare coordinator. And what our aftercare coordinator does is upon admission, that individual will meet with each client 3 to 7 days, their first 3 to 7 days. And with that being said, we'll figure out what their finances are looking like, you know, if they've ever been to a local recovery house. Do they need employment? What is their legal history looking like? Are they stipulated to be here? And from there, we will try to get them connected with the best fit for them. Like Ashley Cayley had mentioned earlier, there are a lot of sober living facilities, housing, recovery houses in Lancaster City that we do work closely with. And one thing about Perform Care that they offer are different scholarships. So if a client does not have access to supportive funding or financial support, we're able to get them to apply for scholarships so that they can have some help paying that rent. Physician, psychiatrist. So along with Melissa, we also have a nurse who is on staff Monday through Friday. So what he will do is he will meet with clients upon admission to review their medications, review any current medical issues. Every now and then we do get individuals in that do require detox before coming to us. And so then we will delegate all of that with him. And then he works closely with Melissa with triaging different needs, medication management, and if there's any MAT that's needed as well. Something awesome as well that we do is we work directly with the Second Chance program. We do get a lot of clients in our care that are given another opportunity through the legal system to kind of get their life back on track. And with that, we are very lucky to be able to work with different CRSs. They are super helpful. Transportation and technical support is needed, but most importantly, we all have to work together. We all, with intentions to provide care without compromise. So the treatment team collaboration is super important. Everybody's opinion counts. When it comes to case consults and discussing everybody, all of those opinions matter, especially because each treatment team sees clients in different settings and different environments. So it's really important to kind of put our heads together and discuss what's best for that individual. So these are just some of the therapeutic approaches that we utilize. So just kind of going down there, we have CBT, motivational interviewing, DBT, guided imagery, client-centered therapy, goal-oriented therapy, creative therapies, solution-focused therapies, and crisis intervention. So it depends greatly on the therapist and what they're comfortable utilizing in the styles, as well as the clientele and kind of like what they're looking for and what their needs are. So for example, you might see motivational interviewing being utilized more for clients that require a lot of prompting, or that might be struggling with opening up and processing certain things. You will see with DBT that you might utilize that more with clients that were diagnosed with borderline personality disorder. So it just depends on diagnosis and on what works for the clients, and it just depends. So that's kind of hard to determine ahead of time. So the way that our treatment schedules are set up under group therapy, we offer process groups, psychoeducation, experiential, application hour. So process group is ran from 9:30 to 11. Those are considered small groups. It's anywhere from, I would say, 8 to 10 individuals with their primary therapist. And what this allows for them to do is to check in. It's a time to vent. It's a time to share with where they're at, any current concerns, any achievements. It's just a very intimate setting, and it's very beneficial. Following process groups, we have a psychoeducational group, which is ran from 11:15 to 12:30. And this is 7 days a week, including Sundays. There are no off days. Psychoeducation, it's kind of just like the way it sounds, psychoeducation. So pretty much it's just educating the clientele on a specific topic, whether it's grief and loss, trauma, acceptance, whatever the case may be for that day, based on our 28-day curriculum. Following psychoeducation is experiential. Experiential is held from 1:15 to 2:15. I like to think of it as holistic and kind of hands-on. So say for psychoeducation, you were talking about grief and loss. Well, then in experiential, you might be writing letters and, kind of processing further with the grief and loss. Another one that we offer is application hour, and that's from 2:30 to 3:30. Some of the clients think that it's an elective hour. It's not, but we offer different focus groups, such as vocational, life skills, coping skills, mindfulness, spirituality, and to kind of get into detail what those courses look like exactly. We offer the gym. We do take the clients to a private gym where they do have the opportunity to work out. I think it's a wonderful coping skill. We provide art therapy, music therapy, budgeting courses and credit repair courses, recovery exploration, refuge recovery, 12-step recovery. We offer parenting classes, meditation, and one that's really popular that we offer is yoga. So with the application hour, this does help clients being able to identify more coping skills and try out different things that they may have not have tried before. Another thing that's really awesome about us is that we do have a computer lab on site. So we do give clients the opportunity to access anything that they may need regarding emails, job searching. So we provide that part there to kind of give them the extra push that they may need with taking initiative of their lives ultimately. So looking at the Chapter 1 focus groups, this is what we determine after an eval is done. So the evaluator whoever assessed that individual will come see a supervisor, and we will sit down, we will go over the case summary and discuss what we think would be the best fit. So each primary therapist has a different group that they may be assigned to. It's usually 2 primary therapists per group. Group 1 is focused on mental health. In this group, we're trying to help individuals identify healthy coping skills that they can utilize. And we also help with psychotropic medication management. And more than anything, we help educate them on their diagnosis and explore further in regards to what's it going to look like moving forward. Almost every person that we do get in here has mental health diagnoses and has trauma, but just to kind of split them up with whatever one we think is more fit. So for group 2, we have a trauma group. It's more trauma informed. We teach them stress management. We help them establish supports, creating safety and vulnerability, and mindfulness interventions. Group 3, this one is actually very unique. We have a mind, body, and spirit track. What we utilize here is introduction to relaxation techniques, spirituality, philosophical exploration, aromatherapy, and different holistic approaches. So in this one, you're going to see a lot about like a couple groups that we offer based off this is like Reiki. We offer Zentel, just very spiritual based things. Every now and then you do get clients in that prefer one group over the other, and that's okay. We don't ever want anybody to feel uncomfortable in their track groups. We want to make sure that it does fit their needs and that their needs are being met. So these are subject to change depending on the progress that is being made at the time. And kind of to follow up, I'm sure people might be wondering what our COVID-19 protocols are. So if clients are symptomatic at all, whether they're sneezing, coughing, reporting any chest colds, we do take them for COVID testing as soon as possible. Based off of the apartment styles, we are able to quarantine clients. They do sign telehealth consents, and then we call them into groups, whether it's video call, FaceTime, Zoom, or they can call our landlines, and we do the same thing for individuals. Due to us having on a daily basis having direct physical contact with clients, it is required that all staff do wear masks. We do encourage the clients to wear masks, but they are a little bit difficult about that. And we do a lot of temperature loggings, and we clean nonstop just to keep it safe and just clean. So that is the way that we operate right now with the COVID-19 protocol. But the most important thing is, and I try to get people to understand this, that the PHP program here is not just chapter 1. Chapter 1 altogether is anywhere from 6 months to a year, and that includes IOP and OP services. It can be determined based on if you're requesting extensions on partial hospitalization or an IOP, and as well as relapses. So every now and then somebody will step down to chapter 2, which is IOP, and be referred back up to chapter 1 as a result of a lapse in that level of care. Just to give you guys a little bit of back history, I started as one of the primary therapists back in February 2018 of this program, and it's been a pleasure to watch this program develop from 20 clients max to 50 max. We work with different people as long as we can accommodate medical stuff, and also too, we're not dual diagnosis. We do work with people that do have mental health, but we are not a dual diagnosis program. At any point, if we do feel that nobody fits this level of care, we will refer them, and we work as a team with doing so. Does anybody have any questions for me? Sorry guys, I talk really fast. All right.
So, one of the things that Alexis brought up that made me think was she was talking about the aftercare coordinators, and that's actually, she was talking about the Blueprints aftercare coordinators. So if you're kind of trying to keep track of everything, we went from that inpatient level of care, so like that 28-day like residential inpatient level that Lori had been discussing. And there's a couple different ones. So if you think about, for example, in this area, we looked at places like Retreat Behavioral Health or White Deer Run. So places like that, a lot of times where the PHP is that step down level. So we do a lot of work. So especially Ashley with the admissions team, and then also me doing the outreach of connecting with those aftercare coordinators. This is something I didn't touch up on quite as much earlier, but it's very important to know these aftercare coordinators because they have numerous people that come through the doors looking for what to do next. There's always that step down process. some people really want to just go home and go continue their lives. And it's also one of those things that's just, you know, it's usually not always in the best interest. So like the way I like to talk about PHP to people is it's like that gap between inpatient to the real world. So I'm going to talk a little bit later about the aftercare, a little more about aftercare and transitioning out of different treatment fields. So it's real important to have programs like this around because it does give you that flexibility, but it's also like a monitored thing. So what we're going to do, we'll take a brief break here. We're going to be rejoined by Deb Smith and Clarice Tinson, who will discuss the outpatient level of care. And again, any questions that you have, please do send them our way. We'll be happy to answer them. And again, if there's anything that might come up between that, you know, from a prior speaker, we can always get those questions over to them, or we can answer them to the best of our ability. So if we don't know those answers, we can pass that on. So we'll take a brief break, and then Deb will rejoin us right around 1:50 or so. So. Again. There we go. Okay, now we go.
Okay. So I'm going to go over the process for the admission to IOP and OP. And currently right now we are using telehealth services here in Lancaster for all of our meetings. So we do have our clients download the GoTo app. I think Dan Hamilton, our IT director, did talk a little bit about that. It is very HIPAA compliant. So we have the clients download the GoToMeeting app, and then they receive an email, usually 2 hours prior to the start of their group, and that is their sign-in. Wait, which way? No, it's not moving. We're having some technical difficulties.
There we go.
There we are. Okay. All right. So We do also get verbal consent for telehealth services. So when our clinicians are doing their group notes, this is the verbiage here that they use. They will use the client's name and then use this statement here. And a lot of that is used for billing purposes also, so that the billing department knows that we were doing telehealth. Urine drug screens during COVID-19. In the beginning of the pandemic, we did not have clients coming in to the site to give urine drug screens, but now we are bringing clients in for those screenings. We also did some client surveys just to see how clients were feeling about the telehealth process. A lot of them do prefer the in-person, but we're happy with the flexibility of telehealth. We're able to do a lot more individual sessions with clients. They felt that in-person group settings were better. And also they're better for individuals that have issues with travel. When we do have in-person IOP groups and OP groups, we do provide transportation for the IOP level of care. But generally with this, our groups are 3 hours, 3 days a week. So depending on the route and the amount of clients that do require transportation, they can be picked up an hour before the group actually starts to get here to Blueprints by 9:30. And so it extends their time in treatment from the 3 hours to 5 hours, because 2 hours before and at the end is in transportation. We are currently doing in-person evaluations here at our Lancaster office. So when clients do come into our office, they are signing an initial release for telemed services. We do the in-person evaluation, and that does help us. It's one of the tools to determine the level of treatment, whether it's going to be inpatient, PHP, IOP, OP, or individuals. Many times clients come in to our office for evaluations, and it's based on a need for probation or parole, or they are court mandated to come in here. Our evaluations are usually done in under 2 hours, and we do get a urinalysis taken upon arrival or before the end of their evaluation. And I'm going to go over our intake process. There's a lot of moving parts to it. So what we did is we created an intake assessment checklist just to ensure that all of our intake coordinators and or clinicians who are doing that make sure that they do cover every area. And I know that Laurie King touched on the Eurica, and what that is it's one of the tools that we use to determine a client's stage of change that they're in. The Eurica stands for University of Rhode Island Change Assessment, and this is what that looks like. And pretty much what it is, it's a series of questions, 24 questions, and based on the client's answer, there's a little key down here on the second page to the right, where we can usually see what stage of change our client is in. And let me see. Dave, what's happening here?
What are you trying to go to? Are you getting the wrong thing? You're trying to go to the next one?
Yeah. Okay, thank you. So this is a chart of the stage of change. The majority of clients that we see are usually in the first 4 stages of change: the pre-contemplation, contemplation, preparation, and action. So again, we use that Eurica to determine what stage of change they are in. And so we'll just go through the checklist. Again, we do get a urine drug screen on them. They sign our notice of practice, privacy practice, which is our HIPAA, the informed consent for treatment and assessments. The clinician and the counselor or the intake coordinator both sign this. We have the client sign a liability waiver, just in case there would be any injury while they were on the property. We do an MAT note, which is the medication assisted treatment note, to find out if the client is currently or interested in any MAT, and then we'll give them a little information on the things that can be provided for that. There's also a series of releases, the release of information that we do get on the clients. So we do get an emergency contact, their insurance company or the policyholder, if they have a PCP or prescribing doctor for any medication that they're on. Legal would be probation, state parole, any attorneys that they may have that they need to keep, we need to keep in contact with, and for the referral source. A lot of times we will contact, if a client is coming from another treatment facility, we'll contact them and just let them know that they have arrived and they are participating in treatment. If a client is living in a recovery house, a lot of times the recovery houses, they just want updated that the client is participating in treatment. And then I'm going to go over our intake assessment and just cover the areas that we do cover in our assessment. This is another tool that we use to make a determination for their level of care, in addition to the Eureka. So what we do is we start out with a history of presenting illness. So we'll ask the clients, what brought you here? A lot of times clients will tell us probation, or the judge said I have to be here. So we kind of, and then we also want to know what kind of consequences that they've had as a result of their using. We'll get a history of drug use. So we'll find out what the drug of choice is, the amount used, the route of administration, the frequency, the longest period of abstinence that they've had from the drug, and the age that they first used and last used. And we'll do that with each drug that they use, starting out with their main drug of choice first. We'll also go through and we'll see if they're in that area of mild, moderate, or severe by just asking some questions, such as, did they find that they have to use larger amounts to get the effect? Did they have the inability to cut back on that drug? Was there excessive time spent looking for the drug? Talking about cravings, failure to fulfill, persistent and physical problems that they may have had. And then we'll move on to a psych history and just see if they've had any. We'll start out with the withdrawal, see if they've had any seizures, any DTs, any past psych hospitalizations or outpatient psychs, suicidal or self-injurious behaviors, assault, medications that they may be prescribed, psychotropic medications mainly in this area, trauma, grief, and loss. We will then go to their medical history. So we want to find out, do they have any allergies to any medications or any foods? Past medical histories, current medications. We cover height, weight. Are they practicing safe sex? Do they need testing for STIs? Sleep patterns, infectious disease, TB screenings, pain. And we also go over their tobacco use. And we do offer everybody the number 1-800-QUIT-NOW if they are interested in stopping smoking while they're in treatment. We then move on to the social and developmental history. So we want to find out psychosocial issues. We always ask our clients to, if there's any weapons in the house and if they are secured. We go through abuse and neglect. With our intake coordinators, though, they keep that at a very minimal because we don't want them opening up and having the client divulge a lot about past trauma history or any type of abuse. That's going to be left for the counselors to work with them on. We find out if they have any children, criminal justice history, any cultural or religious beliefs, educational, employment, financial status. We also do a gambling screening on the clients, gender and sexuality, what their housing is, military history, relationship, marriage, support system, and then we do a SNAP assessment, which is basically their strengths, needs, abilities, and preferences. And then they're able to set some goals there. We then move on to the family mental health history. And generally we'll ask the clients if there's any history of any mental health in their family that's been diagnosed by a doctor, because a lot of the clients will say my whole family is crazy. But we want to make sure that it's been diagnosed by a doctor. We'll also find out if there's any history of substance abuse in the family. We do a mental status exam, and basically that consists of their appearance, speech, mood, affect, SI, HI, insight, judgment, their anxiety, attention, behavior, and if they're currently going through any withdrawal during the eval. And all of this information that we do obtain, we use this along with the 6 dimensions of the ASAM to make a level of care recommendation for that client. And then the client is then, the intake coordinator will speak with one of the clinicians or myself, and then we'll see which level of care is appropriate for this client. And then we'll put them either in IOP or OP, or we'll make a recommendation to a higher level of care. We do have a lot of clients who will come in and they're sent in by probation or by parole and really minimize their use. So we'll wait until we get the drug screen back. Excuse me. And a lot of times during that, when we get that drug screen back, it will come back with alcohol, fentanyl. So we will then make a level of care recommendation. We've had clients who had a negative urine drug screen, didn't meet the criteria for this level of care. And when we did send a letter to the PO or to the judge, they said that can't be true. But we basically have to go off what the client, the information that the clients give us to make our level of care recommendations. And so then we'll go back here. So once we finish our intake assessment, before we make up do the treatment plan, we'll go in and we'll put in our diagnosis codes. We put in billing codes. We'll add them to a therapy group. That decision will be made by the intake coordinator will come and I'll let them know what group to put them in based on some of the information provided in their eval. We will then come up and we will do a treatment plan for the client. We'll do a relapse prevention plan. The relapse prevention plans include a lot of support numbers of people that they can reach out to. It helps the client to identify to the clinician what their triggers are, what are some behaviors that they feel they exhibit prior to a relapse. We will do an orientation session note in there. We'll give the client a handbook and usually allow the client to try to meet with their counselor just for the introduction. We then do an HI-SI risk assessment. I did mention the mental status exam that we do, and then they'll type up a clinical summary, which basically covers all the areas of that assessment that we completed. We will do an admission note that will go into the client's chart, just stating that who referred them in, whose group they're going into, and when they're going to start. They'll send an email to myself, and then we'll take care of calling their insurance company or faxing the ASAM to perform care. And then we'll send out letters to any referral sources. So we'll send out a letter to probation or parole or to their attorney, just letting them know that John Smith came in on this date, and based on the information he provided, this is the level of care that he's being recommended. Let me see, I think that's everything. Are there any questions? regarding the intake process. How can you, there's a question from Cheryl. How can you do a relapse prevention plan for someone who is new in treatment and doesn't know what a trigger is other than on a gun, or if they're only friends use? Okay, that's a good question. So what we try to do with the clients is when we're trying to identify triggers, we talk to them about different things that are going on in their lives, surrounded by their use. And a lot of people will talk about grief and loss, that this is a big trigger for them to use, broken relationships. So we're able, and we add to these relapse prevention plans all the time. So we're just getting a baseline at the very beginning, but we add to these all the time. And if a client does relapse, we update this with the client also. We give them a copy of it and encourage them to use it. And again, on that relapse prevention plan, they do have phone numbers of support people that they can call. Our number is on there. And we do have CRSs here that if a client is really struggling, we can connect them with the CRS also. Does that answer your question, Cheryl? Okay. Any other questions? Okay. Good.
Thank you to Deb for that. And also another thing too is, you know, there's so much, just kind of going back to that original, when I was talking about the Second Chance program earlier, one of the things that we learn, is from Deb and her team that works with the assessments. So we do assessments like that, like on site, and we'll do some general questions, but you know, the more in-depth the assessment checklist that she has here that she was showing, and a lot of times it's just to kind of get that ball rolling, and then we know that there's a much more heavily in-depth approach that goes to that. So having a team like that can work on that to really figure out more of the root causes of things. And as Cheryl had mentioned, asking about the relapse prevention plan. And a lot of this stuff, it varies amongst who the person is. It's not just due to the substance. It can be many other factors that play a role in that. And I think too, what Clarice will talk about is some of the things that we do with the outpatient groups as well. I know she's working with individuals and groups with outpatient level of care. So with that, I'm going to hand this over to Clarice Tinson. She is a counselor assistant here. She'll be discussing individuals and group outpatient sessions.
Thank you, Dave. Good afternoon, everyone. I'm glad to be here, and I'm glad you're here. Knowledge is a wonderful thing. So I'm here to talk to you about individual and group outpatient treatment. So, which one? Spacebar. For outpatient services, our core program features a length of stay, of course, and that's determined by the client's progress and whether or not they've been meeting their goals. Normally groups are 3 hours, 9 hours of groups a week. That's 3 hours, Monday, Tuesday, Thursday, or Monday, Wednesday, Friday. And then also individual psychotherapy, which is done weekly. We definitely work on CBT skill trainings, DBT skill trainings, medication management services. We integrate psychiatrist services, recovery and peer interventions, and also accountability in community fellowships and support groups. Most of those are referred out or already set up prior to them coming from PHP. So a lot of this stuff is done while they're in PHP before they transition to intensive outpatient or individuals. So, and what Deb went over, by the time they come to the group, we have a pretty good assessment of their needs and what we need to work on, what I would need to work on with them. Again, most of the time we don't get the full truth and nothing but the truth. You have to work with each individual as they come. And the longer they stay, the more they become vulnerable and trusting, and they open up to where you might get some information that wasn't anything. So again, it is all determined by the individual and the information. There's also sober living supports where they coordinate with the individual as to where they'll be living, which they went over already. There's economical employment and psychiatric services and resources that I would refer them to. We work with an employment service that now PA Counseling now offers. So I've referred a lot of our clients there, our individuals there. I work with a program that hired felons. I've referred many individuals there. A lot of them come with legal history. There's food banks, there's clothing banks, educational programs. I've actually even worked with finding some type of scholarship funding. Of course, Deb talked about the daily transportation that they provide. Right now, everything is telehealth. However, if I find that someone's acting suspicious, I could use transportation to pick them up and bring them in for a random drug screen. So our transportation department is very, very helpful. Let's see. In the individual sessions, first, there's building rapport building, and that's just two people getting together and talking about whatever comes up, pretty much. I leave it up to them what they would like to share about with me. Sometimes they don't want to talk, and that's okay too. I usually ask them why they're here, what they want to get from treatment, how would they like to see their lives change for the future, in the future. And pretty much, the conversation just goes from there. And I implement a lot of different things to build rapport with the client or individual, and it takes time. So there's no rush, and I let them know that this is for them, and I thank them every time they show up. So again, even reiterate how they're presenting some self-care. So, and I hope and pray they come back, and lately they have, so this is good. Let's see, they have admitted that they are going, that they don't like the telehealth versus face-to-face. I don't either. So we have something in common. I just thank them and ask them to, look at the grace that we can still connect, and we just continue on from there. I have had some individuals go on vacation, and tease me with pictures of the beach. But still sign into groups or our individual sessions. So I think this has been nothing but a plus, and I'm grateful for it. Let's see, personal connection isn't there. That is true. However, learning new ways to personally connect through some of the different activities that we do with bond building, group building, exercises, sharing our experiences with, the experiences with each other. There are just so many other ways that we can personally connect, even through this system. So it's happening. Use of homework, that's definitely something that I utilize. I'm working with someone right now on grief, and she's been able to, I've given her different worksheets to work on. There's also another individual I'm working with, rebuilding a healthier relationship with their family members. And I've given them some different homework where the whole family will work on it together. So definitely we use homework. Goal settings, I have somewhere to start from, which is from the evaluation. So I have something that they have actually put on their eval when they were asked that question. And most of that are on the eval, and specifically they go into what they would like to achieve. So I start there, and we work from there, and that's how that works. Okay, topics for the group settings. Oh, wow. So many. Again, we do a process group. When we check in, I call it a check-in. When we start group, unless we have someone new, we do what's called a check-in. They examine how they're feeling and use a feeling word. We talk about all types of things, from relapse prevention, triggers, codependency. I've done meditation groups. We talk about literature, NA and AA. We talk about future plans and goals. Definitely gratitude. We talk about healthy and unhealthy habits. We do some self-exploration. We discuss best and worst moments. Self-care is a big one. Personal heroes, anxiety, depression, coping skills, refusal skills. Oh, I do many group activities. We just did one today, actually, where we did some role playing. And I was pretty much the person that was that had the drugs or the alcohol, and I approached each member individually with a scenario, and they had to figure out how they were going to refuse and not pretty much not use, and what they were going to do, what they were going to say, how they were going to behave, and how they were going to cope with the feelings of maybe cravings that might have came from that situation. And they did a great job. So I have a few more things. We talk about the different pathways. We talk about dual diagnosis. We do a lot of exercises on self-affirmations, a lot of mindfulness. We talk about under self-care nutrition. We talk about physical fitness. I have a lot of individuals that use the gym to release anxiety and stress. So we talk about forgiveness, anger management, medication, fear, grief. Let's see here. Isolation, role play, as I had shared with you. So there's a lot of information and different things that we can do even on a Zoom platform. I've even used some of my group activities that I would normally use where we're in the face-to-face settings and found ways to utilize this format. There's one that I use where I might put a label on someone's back, and then the rest of the group members would have to like react that way toward this person, this individual, and they would have to guess what would be on the back. Yes, that's another one that we normally would do in a face-to-face setting, which is the art therapy. So I have found ways to use this on using the telehealth platform. So using the chat, I would block everyone out and maybe send it to or put the tag on the one individual that I would normally put on their back, and then let everybody else know except that person. And then, so we would do it, play that game that way. We've done different other games, such as they're all maybe stranded on an island together, and how would they collectively, you know, survive? And normally I would just sit back. Sometimes I would turn my screen off and just listen to them, to them work on this, you know, staying alive collaboratively, and what they would have and what they would need to stay alive. And so I guess we just learn as this goes on how to utilize the telehealth and system. And I've played for them YouTube videos, we learned things about neuroscience stuff, about the brain, and there's a lot of good information out there. So I've been able to even download some of my forms onto screen that they can all see together. Download music. We use music as well in meditations. Let's see what else. We've been able to do quite a few things actually. And so as we grow, as I learn, I'm always looking things up and learning new stuff. As someone else in here at Blueprints learns something, another clinician, they share it with the rest of us. So we're always learning new ways to keep everyone, our individuals, engaged. Okay, so the group structure, again, if I have a new member that joined the group, I normally start out with that newer member introducing themselves, and that's whatever way they feel comfortable. Some of them might say, "Hi, my name is Jane," and then you'll have someone say, "My name is Jane. I'm a meth addict. I'm connected with children and youth. I also have 3 other charges." You know, however they feel comfortable with, they would just introduce themselves. The other group members then introduce themselves. I go over the group rules, reiterate those again, and the structure of how I run my group. And then we do a check-in. Everyone checks in, they talk about any issues they might have, any barriers, anything they might have done over the weekend, anything they might have had to had to deal with, maybe any triggers, any cravings, any situations that might have came up. Maybe they weren't able to get the ride they needed to get their Vivitrol shot. Maybe they had a family gathering, they was drinking, anything that they want to talk about. I let them know this is their group, this is for them, and there's no judgment in the group, and we respect each other in the group, and that the group is there for them, and they can share anything that they want to. I don't have personally, I don't have a problem with cursing. So if they need to curse, they need to curse. It's about tapping into their truth and what they need to feel and what they need to put out there. Normally we take like a 15-minute break, and then we do an activity. I let them know they need to bring paper and pen or something to write with, crayon, it doesn't matter to me. And I normally do some type of writing activity. For me, when you put things on paper, it takes on a different form. And so I do a lot of writing activities, letters, goodbye letters. We write letters to our addiction, our disease, letters. What would you have told your younger self? Letters, forgiveness letters. I mean, we do a lot of writing. And so I let them know that they need to have that on hand when they come, journals. And I also open it up for any new topics, anything that they want to learn about, anything that they're confused about. Please bring it here. I'm their facilitator. I can find information for them if they need information, and bring it, what I have learned, to the group. Also, the group is open for feedback. I let them know that we respect each other. And so that's another thing that we work on, communication skills. And so there's always feedback. Let's see. Strategies for engagement and re-engagement. So I'm not going to lie and say that it wasn't difficult in the beginning. It was versus face-to-face. But today, as I shared, I'm finding the only difficulty that I'm probably having is I go through glasses quite a bit. I had to throw one in, I'm sorry. Because I'm staring at the machine, at the computer, and there's people on there and moving around, my eyes take a little beating. However, the more I learn and the more that the individuals become comfortable, vulnerable with me, there's not much, I don't have too many problems with keeping them engaged. Again, there's 4 clinicians in this office, so we're all learning. We're all looking for different ways to keep our individuals engaged. And I'm probably one that's a little unorthodox, so I'm always looking for something interesting. Something, most of the time they don't know that they're working on maybe a different skill because of the way the exercise might be, but toward the end, and when we start the feedback and we start talking and discussing more about the topic, then they see how things have, become more aware of actually what they were actually doing. But there is so much out there to learn, and And I'm always searching for some new activity or something to do. I have a couple that I have in my book that works very well that I've used since I've started. And so I'll go back to them. There's a couple that are always just perfect. You can't go wrong with a gratitude list. You can't go wrong with working on them learning about the different pathways that are out there. A lot of times they'll get on and say, I don't want to do those meeting things. I don't want to do this. But when you give them an option and you give them the information and you don't force the one thing down their throat, you give them the different options, they're interested and they stay interested. So now there have been a couple that they re-engage. Well, you need to do some other things to re-engage them. And I try whatever I need to, pretty much. I'll try all types of things. If I know them, I've been in the field for quite some time. I've worked with a few agencies, so I might have worked with these individuals in the past. I've even called them up and said, get your A in group. I mean, I'll do whatever it takes. Now, if they're relapsing or whatever, I'll say something like, can we talk afterwards? Or I'll call them. I call them all. If they don't show up for some reason and didn't let me know, most of the time they'll let me know. Send me an email, call and leave a message, and they'll let me know something came up. But if not, I'm calling them after group to find out what has happened, and if they're okay. Again, just showing the compassion, showing someone cares about them, showing they were missed. I open up my group with thanking them for showing up for themselves, and letting them know that this is something big. And this is something also difficult. This is nothing that's easy. Easy would be them in their state of using. That's what they're used to. That's what they're conditioned to. Not using is abnormal. And so I understand that. And, a lot of times they're very apologetic. No need to apologize. Let's just do something different. And so we learn, and I try to facilitate exercises that will teach them different habits, that they will learn to change their thought patterns. Just by them showing up every week, whether it's twice a week in individuals or 3 times a week in the group settings or once a week in OP, they're practicing now a new way and something new to do. Just like they would go out every day to get their package, just like they would show up every day at the package store, the liquor store, to get their bottle. This is now something new that they have to practice. And so, I just continue to think of different strategies to keep them engaged and do whatever I have to do to re-engage. Again, I open the floor up for them to give me feedback. We do quite a bit of group exercises where they give each other feedback, where they tell each other what they see positive in each other, what they might even think each other should work on. So they're building their own support network. They're building their own family, here at Blueprints. So, let's see. Group engagement. Okay, so again, the different types of activities that I come up with, and I come up with some good ones. the writing circle. We're contracted with a teacher. Well, he used to be a teacher. He just retired. And he actually engages in our my IOP or OP groups probably every 2 weeks. And he's excellent. And he brings in a writing circle. So what he does is he'll throw a poem out there or some topic out to the group, and he'll read some literature or some other poems or writings that some of his other individuals have written, and he'll throw the topic out, and so then my group members would then write what they're feeling, and then again we discuss that. So he's very good. They love him. Again, I share videos, YouTube videos, anything that I might find that I really can't discuss or talk about a lot, like the neuroscience stuff of the brain and different things. People share their stories. So experiences, I find YouTube videos on that. I put up worksheets that I can share on screen. We do music. You know, I ask them maybe to think about a song or a poem or a movie, something that might have brings joy into their lives, something that made them think about someone else, if we're talking about grief, and they participate in that. Or when I do a meditation, you know, I put on the nice ocean background or whatever music, and we'll do a meditation. We play games, all types of games. And usually I'll do a game on a Friday or something. Once in a while I've switched it up, but we do all types of activities. And again, though, I do a lot of writing activities in my groups. Okay. Anyone have any questions? Yes, I do. We do art therapy. Now, sometimes it's a little hard to see depending on what the person has drawn, only because everyone has to look on the screen to see, and the squares aren't so big. But we have done art therapy as well. It's a little different take versus them being in the office. So, and it might not be as colorful. I brought in different, you know, color pens. We've done collages before COVID where I brought in magazines and different things to do different activities. So I've only done actually one art therapy, but it turned out pretty well. However, a lot of, you know, to see it clearly what people have drawn, they usually have to explain it a little bit because the boxes are kind of small, but it was definitely a good session, a good group. I have to find something more that I can do on telehealth. You're welcome, Martha.
All right, Miss Clarice, you mentioned that you call people and follow up, you know, if they don't attend a meeting or something, like a group therapy maybe.
Yes.
Wondering if you have any strategies as to what you do if somebody seems like they're about to drop out of treatment.
Well, I call them up, I talk to them. I let them know that I'm here for them and that they can tell me anything and what's really going on. Like, you know, I don't, they, you know, want to tell me surface things, but really what's really going on. I tell them what I notice. I told them that, you know, I'm here for them. This is where they can get honest. And most of the time they do. They tell me that they used, they're feeling shameful. They tell me that, you know, about going through this situation again, hurting their families. They tell me that maybe Well, I mean, I just had a couple other, going through maybe some type of medical situation where they're in pain, they can't deal with the pain they want to use. You know, I let them know that this is what they need to do, which is talk about these things, and that they're not alone. They're not alone. There's 3 more here that are going through pain. There's other people that have gone through maybe cancer. There's other people that have gone through losing a loved one. I might even share with them some of my own experience. And I let them know that if they feel that if they don't feel comfortable in the group setting, that I'm open to do individuals with them. I let them know how far they have come, that, you know, the things that have already changed. I give them an option, you know, like we can do individuals. I can work with you one-on-one. You know, maybe it's just as simple as they got a job and they don't know that I can move them to an evening group. But I try to give them as many opportunities. I try to, no, I don't try. I let them know that I care. I care, Blueprints cares, and that if they need us, we're here.
Thank you.
Okay. You're welcome, Glenda.
Yeah, thank you.
It is essential that you have an art therapy degree if you are saying you do art therapy versus art as therapy. Well, it's more of an activity. I don't have an art therapy degree. That might be something I might invest in the
This
next
kind of
time.
goes back to some of what we talked about before too, at the higher levels of care. So I know of other facilities that actually do art therapy where they have somebody with a degree. There's a facility that's called Just Believe that's in Carbondale, Pennsylvania. Part of my outreach is visiting other facilities and seeing what they offer. And that was one of the things that when I toured a few months ago, I went to visit to see how everything was going up there. That was something new that they had implemented. Now I would have to check in too to see if that's something they still do, if that person is still employed there, or if they're just doing it more as an activity level, similar to what Clarice does. But again, a lot of what it is that the outpatient level of care is really just trying to keep everyone engaged, and it's so much tougher to do so virtually. Kind of like, you know, we're trying to engage as best we can on something like this, but when we're not actually seeing people, it's hard to know, you know, because you can pick up on social cues like that. And we've done a few surveys with the individuals that have come through that are doing telehealth with us, and it seems that the most common thing is everyone likes that it's accessible, it's easier, but with it being accessible, it's hard to get on the phone in a quiet spot for a few hours a day at a certain time. They like that they don't need to get a ride, even though we can offer transportation at our facility. Not all facilities can offer transportation. That's just kind of a unique aspect of what we can do. But just knowing that because a lot of times people could have a DUI and they don't have a driver's license. They can have a car, but they can't drive it because legally they are not allowed to do so. So we see so much maybe pros and cons of it. We're interested to see where telehealth goes in the future too. You know, if I know there's been spikes of cases in Pennsylvania and throughout the country. So it makes me believe that telehealth is still going to be a thing for a while, but once things are kind of going back, there's a vaccine and then there's more face-to-face. If telehealth is still going to be implemented in our curriculum and how that's going to work. So I think Ashley may have mentioned it earlier that everything is always changing and trying to stay on top of all of that. So that's why, you know, having that cohesive team approach and people in each department to
really come together. I think that a lot of what's been done today so far, even, we're hoping everybody is learning something. And I know I'm learning stuff, Clarice is learning stuff, Ashley's learning, like everybody that's been in here, I've seen people hanging around to listen a little longer because there's different things that are coming out that we're not as plugged in with. We try to know a little bit of everything so that we know where to funnel everything when it comes through.
And maybe this would be something that I could look into, an art therapy degree, a music therapy degree. I didn't know that. All I know is I need to find ways to keep the individuals that I'm working with engaged. I know I don't want them to go back there out and use. I don't know what I'm doing with the music therapy or the art therapy. I'm reading something that I've found on the internet that said you can use this in therapy. So I'm trying to find a way to keep them engaged. Now, I done been told I done missed my calling on a couple of things. Okay, so now I've done I've done a meditation therapy, and I have quite a few people in my groups that suffer from insomnia. But guess what? They said, oh my God, that has never worked for me. Your voice is so soothing. Oh my God, I went the weekend. I had such a great weekend because I was relaxed. Did I do it right? I don't know. I know they benefited from it. I know I was willing to try it and keep them engaged and teach them how to relax and teach them about being calm and teach them about, how to even do that for themselves. How to sit in a quiet spot. How to hear the birds sit on the porch and hear the birds singing. This is something they didn't listen to before. This is something now that they're clean and sober that they can appreciate little things. This is what's changing in their life. So do I have a degree to practice art therapy or music therapy? No, but I love what I do. And I love when one of my individuals, one of my group members succeed at this thing. Come from PHP to IOP to OP or individuals, and you can see the transformation. I could see it on their faces. I can see the glow come back. I can see the tightness loosen up. I can see that frown, but confused turn into a smile. We can laugh together. This is what we're doing here, teaching them how to live a different way. That includes laughing. That includes sleeping, which some of them have a problem with. And that lady said to me, I was able to get a good night's sleep. My spirit was calm. That's what I want to do, connect to their spirit. So maybe I'm in the wrong place, KB. Maybe I need to look into that art therapy or that music therapy so I can have a couple more letters behind my name. I don't know, but I'm going to try what I need to keep them coming.
All right, without a doubt, you have a therapeutic presence with clients, without a doubt. You're absolutely demonstrating that in what you're sharing and speaking about. And we do have until about 3:30 to finish our training. I'm not cutting you off.
Oh, that's okay.
No, I'm just jumping in because I'd really like to encourage other people to jump on the camera and ask a question or engage in conversation while we still have the time, right? Because virtual trainings are tough. You guys have been doing a great job with a virtual training, but it is tough because you don't feel as connected to the audience because you can't see them, right?
Oh, no. Okay. Well, yeah, you're right. And I let them know I need to see them. I'm in that big room by myself. So I want to be a part of as well. And so I asked them, please come on the camera. Let me see their beautiful faces. And they pop on one after another, or they come right on, and So yes, you're absolutely right, Gwenda.
Yeah.
That would be excellent. Thank you.
If everybody joins at once right now, we could lose the call. So I'm just
Yeah.
gonna do that. But if you would like to say a comment or ask a question, please do it, all right? While we're still together before 3:30. Thank you.
And there's another question I see there too, is asking if Blueprints is just in Pennsylvania. And yet, yes, we are. I'm not sure where you're located, so I apologize, but we are doing this training from our outpatient facility in Lancaster, Pennsylvania, over in Greenfield. We have our PHP facility is in Mount Joy, Pennsylvania, with residential units in Columbia and Helen, Pennsylvania, and also IOP and general outpatient and intensive outpatient facilities located in York, Pennsylvania, near the WellSpan Hospital. With that said, we work with, part of my, I don't know if you're on in the morning or not, but in the morning I was talking about the outreach aspect of treatment facilities and how we work with numerous partners throughout. So a lot of times we'll get people that want like our level of a level of service of PHP, but they're out of state. And when Ashley and Brooke had talked about earlier with insurance, you cross state lines and things start to change with what can be accepted. So we can take medical assistance here, which is awesome, but it only can cover certain counties. So you're saying you're in Pittsburgh, would love to be part of this organization. And hey, we can talk more, we'll definitely connect. I can put my email address into our, in fact, I'm going to do this now so everyone has it, because there may be other questions that come up. And if you're not sure who the person was that you need to send the email address to, since I do outreach work here, I usually funnel stuff through to the rest of the organization anyway. So I'm going to send you this. So, and yeah, I guess Gwen could answer that question too about the PowerPoint presentations as well. I know someone got sent out to the people in the OEP board. Just as a reminder for that too, one of our CRSs, Eric, is going to be doing a Narcan training on Monday with one of the interns, I believe, not interns, but one of the OEP students that's over there. I think that's part of her internship. So we do appreciate you doing that. And that kind of goes back to what I was discussing about my personal recovery of myself. When I first got into recovery was in college, and I did not have any awareness of resources and the kinds of resources that are becoming available today, and that stigma is getting knocked down. We're starting to see communities, like we're seeing the hospitals, we're seeing the schools, we're seeing everything else. It's really just like very accepting and understanding of the drug and alcohol treatment field and what goes into that. And things are always changing, like we had said, and it's not always going to be things that worked before, and they may need to change a little bit, and that's for all levels of care. So just kind of to recap what we've talked about today. We started out with the outreach section, and Ashley then talked about the entry to care and the ease of access with that, and the obstacles that you may find. And Brooke and Dan touched up on the billing and the technology aspect, which we're seeing as a huge part of the treatment field as well, with the telehealth becoming much more utilized, and we don't think it's going to go away, but we don't know for sure like what's going to happen. But we need to make sure everything meets HIPAA compliance, because being part of the Joint Commission and DDAP certified organization, there's no corners to cut, and obviously that's the last thing anyone wants to do. And then with Melissa Callahan, really did a dynamite job talking about the withdrawal management and MAT. And MAT is another thing that we're seeing is becoming much more more utilized, and seeing the community using that and having a better understanding of that helps us as treatment professionals as well. And we see that too. We're seeing like some people look at MAT like, oh, it's just like, some people just right away imagine it's like, oh, this is just like some magical pill to stay sober. But, you know, hopefully we're able to present that, you know, it's just another tool. It's a resource. There's just so much more to that. And it's different for every person. So with Lori talking about that residential level of care, that step down to PHP, and now outpatient, I'm going to try to wrap things up here to talk about aftercare and long-term recovery. There's a lot that goes into that. There's lots of different levels, different ways to stay sober, and most common that I'm sure everyone is aware of are 12-step fellowships, you know, and 12-step fellowships being Alcoholics Anonymous and Narcotics Anonymous are two of the more common ones. There's also Al-Anon and Nar-Anon. I'll touch up on those. Also talking about recovery houses and real world. And when I'm saying real world, I'm talking about life after, like the recovery houses, life after inpatient, like where we're getting to that level of freedom to become productive members of society again. And that's the long-term goal of the continuum of care. That's where we see that tail end and that community involvement. Sometimes we need that help, and that's okay. Relapse is going to happen. And that stigma, when that stigma is going away, people aren't as scared to reach out asking for that help. And we hope that what we're able to provide today is to help people understand that, you know, this is a disease. It's not just, you know, doesn't matter how people get there. It's just, if they have that willingness to get the help, to know that that help's available. And that's all levels of care. And that's not just something we're saying like, oh, we're just Blueprints for Addiction Recovery, come to us. No, that's nothing to do with what we're doing today. Today, what we're doing is we're passionate about our work. I mean, I can say from my own personal experience, I'd left Blueprints for Addiction Recovery to go to another job that paid a little more money. And guess what? I hated it. I came back here within 2 months because I like the idea that I can help people. So what I want to talk about with aftercare, part of that is 12-step fellowships. And as I mentioned, Alcoholics Anonymous, Narcotics Anonymous, Al-Anon, and Nar-Anon. So just to talk a little bit about Alcoholics Anonymous is when the big book of Alcoholics Anonymous was first published, there was about 100 people that had got sober. Today, there are millions. These numbers that are on the screen, this is an estimate. You know, this is a good ballpark. You know, we're seeing over 1.5 million members in North America right now in Alcoholics Anonymous. And that's through correctional facilities as well. And outside the US and Canada, another 500,000. I'm sure you're tired of seeing a lot of numbers on screens. We're not going to do a big map with blue or red on them. We're just going to talk about, you know, these are just some numbers. We're not 100% on how accurate these numbers are, but, you know, this is December 31st, 2019. And, you know, COVID-19 hitting in March of this year really changed the landscape of 12-step fellowships, where everything pretty much went virtually. We're starting to see that meetings are starting to open up again throughout the country, but they're on a limited basis. So again, the technology aspect is becoming a vital key to people's sobriety. Still a brief history on Alcoholics Anonymous as well. AA had its beginnings in 1935 in Akron, Ohio, and it was the outcome of a meeting between two gentlemen named Bill W. and Dr. Bob. Bill W. was a New York stockbroker, and Dr. Bob was a surgeon. And this was, so 1935, here we are in 2020, and this is still a thing, right? Both were considered hopeless alcoholics, and prior to that, they had been in contact with a group called the Oxford Group. which is where the 12 Steps of Alcoholics Anonymous it originated from that. So in the Oxford groups, there was a Episcopal clergyman by the name of Samuel Shoemaker, and under his spiritual influence, with the help of a friend named Ebby T, Bill got sober, and he actually maintained recovery by working with other alcoholics. So all the clinical aspects are you're kind of seeing, like working with others, helping others. This helped him working with other people and helping them with their sobriety. What worked for him, he tried to just pass that message on to what can maybe work for you. And with Alcoholics Anonymous, it's not like a rule of like, you have to do this. They're called suggestions. They give these suggestions and they can try it. If it works, great. If not, that's okay too. Try again. So when Dr. Bob and Bill met in 1935, they found themselves with another sufferer, and they call him AA number 3. And they learned of each other's work through the Towns Hospital in New York, where Bill was a patient, and through a physician, Dr. Bob had not known alcoholism to be known as a disease. So responding to Bill's convincing ideas, he soon got sober, never to drink again. And this is the spark that found AA. There's a lot of history to AA. They're AA historians. I'm not going to claim myself to be an AA historian. I can tell you some experience and stuff that I've learned along the way. There are books out there. There's one that's called, I was recommended this book recently, and I should probably read it, but I have 2 kids at home. They make that really hard to find free time. But there's a book by the name of Not God by Ernest Kurtz, which is a great outline of the history of AA. He had rigorously studied AA as his PhD. And they got its title from alcoholics not needing to change their view on life and themselves with the understanding that they are not God. So you're hearing the word God, right? Is this a religious thing? Is it a religious organization? And the answer is no. It's a spiritual organization. People use their own conception of what they choose to call God, or as you may hear in circles, a higher power. And their Alcoholics Anonymous, it works through what's called the Big Book. There's 12 steps and 12 traditions in there. I'm sure you've seen this before. See sponsorship and step work, and the sponsor is similar to what Bill was, passing on what was passed on to him. And that's how Alcoholics Anonymous and also Narcotics Anonymous works too. They adopted from each other. They both have home groups and service commitments. And a home group is a Alcoholics Anonymous or Narcotics Anonymous group. And that's organized by people within those fellowships. So those numbers you saw before, those people are going to churches, they're meeting with the churches, and it's not just a church. I'm just using a church as an example. They're in rec halls, wherever there's meeting space that people are willing to let them use. And a lot of times people will just let them use it for free, but usually the group is willing to give donations for them, allowing them access to that. It's just a place for people to get together and meet and talk. There's numerous formats. There's speaker formats, there's big book studies. There's another book, it's called the 12 and 12, which is 12 steps and 12 traditions. I can't touch up as much on Narcotics Anonymous on if they do that too, but I know that there are, there's different formats at each level. So this is the very common known organization that people use for that aftercare. It's not a requirement by any means. I'm not here to promote it by any means. I just know it works for certain people, and it doesn't work for everyone, and that's okay. A lot of times there's alternatives that people may look at on top of it or instead of it. Sometimes, I've worked with people that have done really well in one fellowship for 2-3 years, doing great, and then they're struggling. So So why don't you switch it up? Maybe try a different meeting. If that meeting doesn't work, you can check out Narcotics Anonymous. There's no requirement that being in Alcoholics Anonymous means I'm only here because I drank. I'm in Narcotics Anonymous because, I only use substances like heroin. Basically, whatever works for you, there's kind of a trial and error kind of thing. You can work a little differently. I've seen people do more than just AA and more than just NA. A lot of people get involved in churches. There's some groups within the churches. But based off the 12 steps of Alcoholics Anonymous and Narcotics Anonymous, there's groups called Al-Anon and Nar-Anon. These programs complement other forms of therapy and treatment that can't easily be achieved within a medical setting. So these groups are for the families of the alcoholic or the addict. So the person that may be going through, their mom and dad, their kids, they could either be sober or not sober, but whatever it is, this is a place for the family to go. And this, again, it's not like a for-profit organization. This is just another place where people can share their experience, strength, and hope with each other. And it's in order to solve their common problems. And they believe that alcoholism is a family illness and that changed attitudes can aid the recovery. So as much as the family member may be hurting, they want what's best for say it's their son that's, say they need to take care of themselves, because if they're not taking care of themselves, they're no good to when that their son or daughter, whomever it is ready to get treatment. Because that's the thing that we always have to remember is if you're not willing to get that help, you can't get forced into it. Something we talked about before with the CRS programs. You can help people and guide them and give suggestions. You can give them rides to meetings, take them to the food bank or whatever it is that they need just to help them out and get off their feet. If they don't have that willingness, there's only so much you can do. And it can be unfortunate, but with that, I did mention about there's some alternative groups as well. This is just a basic list of Smart Recovery, Life Ring, Women for Sobriety, Secular Organizations for Sobriety, Moderation Management. There's another group too. There's other groups throughout the county as well. A lot of churches have organizations. I know that there's one that's called Celebrate Recovery, which is I believe it's the LCBC Church in, I guess that's East Petersburg or Mannheim. It's in Mannheim. Couldn't remember exactly where it was, but it's a similar kind of approach. Again, a lot of these approaches it's not so much of that completely clinical level, but more of working on yourself and like that. A lot of it does involve some spiritual programs, but it's not all of that. It's not stating like it's not a religious organization. There is actually a chapter within the Alcoholics Anonymous Big Book called We Agnostic. So it's basically saying like, even if you do not have like that belief in God, there is ways that you can still get sober and use the 12 steps of Alcoholics Anonymous or Narcotics Anonymous in your daily life. We talked a little bit about recovery houses earlier. And this is a really good aftercare tool to use. Clarice was talking a lot about her group, and especially when COVID hit, like to really reach out to those recovery house owners as house managers to let them know like, hey, here's what we're doing. We're not going to be picking up people to bring them to outpatient anymore. It's going to be over the phone. We're doing telehealth. So just like having that connection to let them know, because a lot of things have changed. But basically, a recovery house is a structured sober living community to help transition into long-term recovery. There's numerous ones throughout the county. Again, when I discussed the history of Blueprints, I talked about how there was really only one recovery house in the area at the time, or probably in the early 2000s. There was maybe one or two, maybe three different groups, like different names for recovery houses. So they may have had a few houses, but it's basically like it's just a place for people to go after inpatient or after PHP. Generally speaking, a recovery house will require an individual to attend some outpatient from other facilities such as ours or any other outpatient facility. Or if there's maybe more of a mental health thing, they may go to CSG or PA counseling services. Meetings are usually required. I say 12-step meetings on this slide. It doesn't have to be 12-step meetings. Again, there's a few other organizations, just as long as there's a way to show that, like, you know, they're working on their recovery. And there's a, you know, obviously you do have to pay weekly rent. Unfortunately, with recovery houses, there aren't, you know, they don't take insurance there. So even if you have insurance, and you can't, you know, they can't take that as a payment. So it is still, though, it's kind of helping work in that transition. You know, Alexis talked about PHP, where people are learning how to cook. They have those kitchens to learn how to cook. Now, the goal of that was to get that life skills to now move on to that recovery house. I myself was in a recovery house years ago, and I was a bad cook. And I've done a little better at cooking, but I have a wife that does that now. But she's much better at cooking. But there's the importance of a recovery house is that community and peer support and connections, because we talked about, you heard someone had asked a question about triggers before, and a lot of times you're going to see that stuff happen. When you're going through those first couple months in your recovery, you know, you'll hear people talk about that pink cloud where it's like you're just feeling really good, and all of a sudden it's, oh, life is showing up. What do I do? That's because that alcohol and drugs were my solution. Now what? I don't have that solution. And having that peer support of other alcoholics or people in recovery in that same house goes a long way. And usually these places, they're placed in more convenient locations that are close to like a bus route, because we understand that people are not going to have transportation. Some of the houses won't allow you to have your car right away. Even if you have a car, they do blackout periods, so maybe 30 days you can't have your car. But if you do have a car there, a lot of times they want you to help take those people to meetings in the area. So that goes back to what we were talking about with AA and NA and the service work aspect. That's part of what we're talking about. And mainly the recovery houses are there too to help establish responsibility and accountability. You'll see that there are some houses do allow MAT. I think their houses are getting a little more receptive of that. In the past, you would hear like a lot of houses would not want that. But I'm starting to see more and more houses willing to allow that. And again, there's definitely security measures that go into that. So I am familiar of a house that does it, but it's administered through lock boxes and everything. Like, it's not just out in the open. And they have to have, you know, they have to have a primary care physician as well. And finally, on the recovery houses, there are scholarship programs, since, like we said, there's people, when you're getting out of inpatient or PHP, you're more than likely not working. But you have to pay rent. Sometimes your parents can help, which is nice. Other times there's back rent is offered, but there's also a lot of scholarship programs as well. And we were talking earlier about aftercare coordinators. And a lot of times what aftercare coordinators will do is work with the individual to apply for scholarships. I can talk about, there's a scholarship board. I'm a chairperson on a board called the Mighty Mahal Foundation. And the Mighty Mahal Foundation is named after a friend of ours that overdosed and passed away. And his girlfriend at the time was looking for a way to get involved, to give back, to help. Because she said, you know, he was always helping people. I want to help like he did. And here she is, not knowing like that her life would ever be affected like this. And now she's very involved in the community, doing her own outreach on her own time to raise awareness. We've done casino nights, sober casino nights. And we've done other fundraisers where we've worked to to raise money in hopes that we can give out at least, we've been able to give out at least one scholarship a month. We've been able to do 2 or 3 in other months to basically cover that, the intake fee in the first month of rent for individuals looking to get into recovery houses. And what's been beautiful about that is we're seeing people that had no idea about how much OUD and SUD, how big of a deal it is and how much it affects people within the community. But to see that's just the other people working through that. And really again, we said the word stigma a few times, say it again, it's breaking down a lot of those walls. Because they're just seeing that hey, these are real people that have something going on. If you have cancer, people are going to do what they can to raise money to help them. And this is a similar thing where, it is looked upon as a disease, and it requires that long-term treatment, like that long-term continuum of care that we've hopefully been able to cover much more thoroughly today. And again, we only have a few hours to cover it, and everybody, we're trying to cover it in the most general ways.
Right, and Terry. So I think that you said a plan, but I kind
I'm sorry? Well, I wasn't sure if that was a question or not. Okay. All right. So, in talking about the real world, this kind of goes back to the groups we talked about: Alcoholics Anonymous, Narcotics Anonymous, alternative recovery groups, whatever ones they are, having that connection. So, we start to see where people a lot of times can, and this is also very vital with a CRS too, when they're working with an individual. And I'll go back to what the CRS role a little bit when I talk about this. It's very vital for the CRS to have these realizations, to talk to the individual that's in more of a long-term recovery phase, where they're, hey, I'm going to be leaving my recovery house soon. I'm going to be moving into my own place. I got this job, et cetera, et cetera, et cetera. You start putting all these other things first, and then next thing you know, they're kind of miserable again, and a relapse could be right around the corner. So it's it's vital to have that strong connection within a recovery community with like-minded individuals. Not to say that those are the only people you can hang out with. Not to say you'll never be able to hang out with people that drink or do that. Well, hopefully you're not hanging out with people that are doing certain other substances, but like a social drinker, let's leave it at that. Okay. I'm not saying oh yeah, go hang out with someone that's smoking meth or something. That's probably not the best idea, but that connection within the recovery community can come from going to different meetings, 12-step meetings, things of that. If you're not sure, we always we do a lot of outreach after the fact. When people are discharged from our facility, we'll give them phone calls, usually a 7, 60, and 120 days, just kind of checking in, because those are important milestones. I believe those are the numbers, right? 180, 760 and 180, because those are very imperative numbers for the discharge period. And a lot of times too, you can check in, someone's doing really good at that 60-day mark, and really things are coming back. I'm working, I'm able to pay my bills, made that connection with my family again. And we're seeing lives getting repaired and people being reunited. But then by that 180-day mark, we can make that call, and they're not doing too good. You might want to come back in and talk to someone, or they may have had a slip up, but they didn't have enough in them to admit it to somebody. So it's vital to have organizations like that can reach out. And that's, with us having CRSs, and we're seeing it too with other facilities. I've actually reached out to a group in Harrisburg that is utilizing the CRS services in Lancaster County in the next month or two to help with job placement for individuals that are leaving inpatient and PHP, and also to work with the recovery houses in the area. So I was saying about spiritual or religious practice, a lot of times people they might not do any meetings, and that's okay. They might not do 12-step meetings. They might go to church, and they find something there that works for them. That's incredible. We see combinations of things. new hobbies and experiences with like-minded individuals. So maybe they were hanging out in Clarissa's group and like, I really like doing that art stuff we did, or they were at PHP doing yoga with Christine and they're like, this feels good. I like working out too. Let's start doing that. And you start to see people doing these things, and it's more that freedom coming. And Melissa talked about MAT, the medication. Medication works great if it's taken properly and administered correctly. That's why it's important that we talked about having that primary care physician, having individuals here. I know, with this being the opioid workforce expansion program, I'm hoping that one day we'll be talking, because you'll be in that workforce. You'll be there, like side by side with us, working cohesively. There's still counseling and therapy. You don't need to stop it. It's not like, hey, you're done with outpatient, you're done with individuals. If it's something you feel you need, like, that can get worked on. If it's not our facility that makes sense, we refer to other places where, hey, you might need more of a one-on-one kind of counselor, or more of a psychiatrist, something like that. Going back to the 1935, Bill Wilson, what was he doing? Helping others. And that still rings true today in 2020. I think Mr. Rogers said, whenever there's doom, I don't know the exact words, I'm totally paraphrasing this, but he says whenever there's like that doom and gloom, which he definitely didn't say doom and gloom, but whatever it was he said go find the helpers. And I, to work with others, help other people, share what's been shared with you to them. And then rebuild and start new relationships. I could just say, I've seen countless individuals that may have been in jail for years, that they had nothing to their name. Then that individual may have gotten a real estate license that he didn't think he would ever get. Then he started a company that helped other people. I've seen so many stories of where you could look at this person and be like, this person has zero hope. They're going to die. And it's probably pretty, and rightfully so, to think that. And I've seen those people basically come back from the grips of death to start new relationships, get married, have kids, buy a house legally. They have a driver's license legally, following the rules of the world and living a happy and joyous life. That's the amazing thing about all of this. Again, there's the continuum of care, as we talked about, is so many levels to it. That was just a general idea of what we shared today. We're very open to talking more to people if they have more questions for any of us. I did throw my email address in there in the chat. I did see a few questions come through. I'm going to check those, and then if there's other questions for me or anyone else in the organization, I did see somebody saying that there was a Blueprints in Washington, PA. That might be a different Blueprints. That wouldn't be us. We're Blueprints for Addiction Recovery. Our website is blueprintsrecovery.com. So I don't know if that shows the exact map on there. I did see another question, Kelly. For me, sorry, I'm just reading the question. Comprehensive list of resources at multiple levels of care in our area based on their level of willingness to get treatment. We could always talk about that too. I mean, we can always help you find different lists of resources. I mean, Kelly, I'm reading what you're writing there. You wrote to everybody in the chat. That's definitely something, if you want to get together to talk to us too. We work with people on a daily basis, on all levels of care, all sorts of resources. If anybody has any other questions, any comments, be happy to answer any of that. I hope you guys learned something. I hope you took something from this today that will help you with your future endeavors. You know, I know it's a Friday. It's like 70 degrees out, which is very normal for this time of year, I'm sure. So I can also get a few email addresses. And Gwen, I guess I can give you the email addresses. Would that help you out? Then we could share it with everybody else. Consultation services. Do you want to? Do you see that one? Could you reiterate that a little bit, Amy? Your question about the consultation services to other organizations needing assistance treating those as substance abuse.
It probably is just better for me to speak.
That's fine.
So the organization that I work for right now, we are called Community Life.
Mm-hmm.
We are currently in Washington County, and we have another one in Bedford County for our day centers, and we provide services to older individuals. And it has come upon us that we are getting more and more people with substance use problems and addiction. So right now we are sort of creating a whole behavioral health department to handle those needs. And we've actually been sort of searching to find more information just to sort of make our program better to service those. So I was just wondering if any of you ever speak to other organizations, maybe, you know, give them information about maybe models that you use or anything like that.
Okay. Yeah, it's not so much from a consultant standpoint. I understand what you're saying now. But what we can do, if you'd like to connect with me personally, we could talk about this. We can set up a meeting together if you'd like to get on a phone call. I'm going to put my email address in here one more time. Probably got lost before. This way, if you'd like to, what we can do, if you'd like to send me an email, send me some times that we can talk. We can find out a little bit more in detail of what it is that you're looking for the individuals that have substance abuse issues. Because again, when it comes to referrals, we understand that, you know, you're saying there's it might be an older population, so you may be talking a lot of Medicare. And when it comes to Medicare, sometimes the options can be limited, and that can be a tough road to navigate around. So we do work with some places. Right off the top of my head, Eagleville and Valley Forge are two resources we use for that. Unfortunately, when it comes to Medicare, the substance abuse is very limited, so can be a tricky one to navigate. But again, we'd love to talk more. If you want to send me an email, and we can set something up to discuss it in further detail to find out more of what goals your organization is looking for.
Yes, thank you. That would be helpful.
Excellent, thanks. All right, anybody else? I don't think I missed any of the questions today. Okay. Well, thank you everyone for participating. Gwen, thank you so much for putting this together, and Danielle as well. I know we had a lot of back and forth. I know we had a few pivots within our schedule and presenters that were available and unavailable. Thank you to my whole team. Not everyone's in here right now, but I think just the way that the presentation went, I think it's just kind of a great example of the cohesive approach of a team working together to help the individual. Amount of times that we see people that may come through and in and out, and just working. Like Clarice talked about how we bounce ideas off each other, figuring out things that may work. There might be new methods that work better for this person. And then you get close to some of these people. It's really interesting how it all comes together.
All right, Dave, I just wanted to say thank you so much. You did an amazing job, a tremendous amount of work to pull together your staff team. I know you spent a lot of time on this. We are so grateful to everybody from Blueprints Recovery for taking the time out of your day to share about the different levels of care and recovery at Blueprints. And you totally demonstrated how to do collaborative teamwork within your organization. So a huge applause for that. I think many of us know that teamwork takes an intentional effort and it doesn't always happen in every workplace. So congratulations on that. I think you guys are extremely responsive and very nimble in your approaches with responding to needs in the community and thinking about how things can be done differently with addressing addiction, as well. So thank you for that.
Thank you. Yeah, and thanks for bearing with us as we had technology problems within the first 5 minutes of the presentation.
Yeah.
So,
and hopefully everybody got to see the evaluation in the chat. The link was put in the chat. Thank you, Danielle, for doing that. And we also have an email ready to go to share that as well, as a follow-up to the training. So we do ask for everybody's evaluation of the training. And on that evaluation, you can also indicate if you're looking for a certificate stating that you attended the training today, or if you're looking for CEUs in particular, and those are basically the 2 items for the training. But we appreciate your evaluation of the training, no matter what the status or what you need, as documentation for the training. So thank you for that.
All right. Thank you for having us, and we'll talk again soon.
Okay, sounds great. Thank you.
Thanks.